for 26.
Thank you, Dr. Shambhavi. First and foremost, this concept, which was conceived by Dr. Samir, Dr. Kaval as chairperson, me as chairperson-elect, to have a platform for the future leaders of our, not our chapter, but for the cause which we are all working. And it's so heartening to see the great phenomenal work which is done by all the young, budding, I would say, stars, the leaders of developmental pediatrics. I will not take any time. I think the platform is theirs, but I will just congratulate everyone, every chapter member who is doing phenomenal work. My salutation to all my fellows and post fellows, and may we all be blessed in whatever we are doing. It's a great cause. I hand over to the future leaders. I find the torch in very safe hands. With these words, my best wishes to all. I hope we'll have a great learning experience today from all of you. Everyone brings a great strength to the topic. Thank you very much. My best wishes.
Thank you, Dr. Zafar. And I would request now Dr. Samir Dalwai, our National Fellowship Coordinator, under whose all the fellowship activities have been happening, and he's been guiding us throughout for different fellowship activities. Over to you, Dr. Samir.
Thank you very much, Dr. Shambhavi. And I have to say that in your secretaryship, the chapter has really got much more better organized. People are far more better connected than even before, and that is a progressive step. I am also my greetings to our dear chapter chairperson, our dear friend, Dr. Kavaljit Singh Multani sir, as well as our chapter chairperson elect, Dr. Zafar Minai, also a very dear friend and brother, and a very big crusader for the cause, as well as all the seniors. Unfortunately, I can see only some names here, but Datar Saab, Nair sir, everybody has joined, and I am grateful to all of you, as well as all our future leaders. As Dr. Zafar has mentioned, this is a different concept by the entire chapter right now to develop future leaders for the cause. Because as we see, the concept of developmental pediatrics and neurodevelopment in India is spreading, we are seeing a very big challenge to look at authenticity. And how do we bring authenticity? Only by bringing our young fellows into the fold. Congratulations and gratitude is also due to all the fellowship coordinators who are running the fellowship over the last large cohort of students or fellows who are no longer students but consultants and our own colleagues who are now going to take this program ahead. And the platform is theirs, as Dr. Zafar Minai has said. Before we go ahead, I also want to make one more point regarding the entire mother body which we all we belong. That is the Indian Academy of Pediatrics. And it is very important for all of us to say that it stays very academic and it stays focused on academics. And that's why not only are juniors required, but also a change in the system is required, where the old system of the same old four people or five people going everywhere to talk and say the same thing again and again and again not only prevents dissemination of knowledge, but also prevents youngsters from honing their skills. Today, we have thrown all of you into the deep end of the sea, knowing fully well that you can swim very well. Even if there are some glitches, it doesn't matter. The point is not just to have a discussion on autism, which is, of course, the topic, and I'm sure all of you will do justice to it. The point is to give confidence to everybody that you can do well. And if you have to do well, you have to study, you have to prepare, and you have to come. And that is what we want to develop, not just in the chapter, but in IAP. We want to take away the system of four people coming and giving the same lecture again. And we want young people to speak. And maybe those who are the so-called experts can only add a few points beyond what you have spoken. And if this succeeds, this experiment succeeds today and in the chapter, then we will try and push for it all across IAP. Because the time for experts to come and keep speaking a monologue and people to hear is not there anymore. People don't come. So with this, I hand it back to our chapter secretary, Dr. Shambhavi, with my best wishes, my love, my affection to all our youngsters who are going to rock the stage. Thank you very much. All the best.
Thank you so much, Dr. Samir. I think the program is already rocking. We have reached our limit
100.
for 100 participants already. And we are live also on YouTube for the same reason. Anyone who's not been able to join on Zoom can see us on YouTube live. And let us just start the proceedings. And we are waiting to hear from our alumni group now. So for the first session, I would request Dr. Indu to be the coordinator, and we'll have a first session. And Dr. Indu, you can please start the screen share.
Thank you, ma'am. On to the scientific sessions where we will explore the mysteries of autism. So session 1 is regarding early identification and screening. So first we have office-based developmental screening and surveillance. Dr. Ahmed Shafi will talk about developmental surveillance in autism. He has done his IAP fellowship in developmental and behavioral pediatrics, as well as his postdoctoral fellowship in developmental pediatrics from CMC Vellore. Currently, he is heading his own center, Dr. Shafi's CDRC at Calicut, Kerala. Welcome, Dr. Shafi.
Hi, good afternoon all. Thanks all for giving a wonderful opportunity. And all our faculties and all legends are before me. I would like to start with all your permission, and you can. So first topic of today is office-based developmental surveillance and development screening. So before going to topic, you should know what is developmental surveillance and development screening. Development surveillance is usually happening in pediatric office, conducted during routine pediatric visit that includes observation, eliciting parental concerns, reviewing developmental history, and monitoring the milestone attainment. While development screening is a brief, standardized, and validated instrument that recommended age or when concern arise to identify children at risk for development delays. So why surveillance is critical in autism? As we all know, ASD often presents before age of 18 months, but goes undetected, especially in a routine pediatric office visit. So as we all know, delayed diagnosis may lead to delayed intervention, and we lose the opportunity of early intervention. So surveillance helps us identify early red flags even before the screening phase. So coming to surveillance. So in first 6 months, that is in early infancy, it's very difficult to diagnose autism. We have to roll out other visual impairment and all other things. But if you're taking an autism perspective, the child develop social communication perspective, interest in social environment around and intent to communicate. So we should look for eye contact within 1 month, social smile within 2 to 3 months, and respond to the voice and the laughing and all start around 4 to 6 months. So coming to late infancy, where the child develop pro-social behavior and improved understanding. So here we have to look for 8 to 9 months where the child develop the name call response, and child develop motor imitation like waving and clapping, and child develop many gestures, or even verbal imitation start. And child also understand the no by the 10 months, and by before 1 year itself, child understands simple request. Then coming to the early toddlerhood, especially by 1 year, the child develop joint attention. Joint attention is the ability of child to communicate the caregivers regarding common focus. So there are two kind of joint attention is there. One is proto-imperative. Here, the child for her needs or his needs point, that's requesting help or object. So it comes around 10 to 12 months. Then proto-declarative come a little later. It's mainly for sharing interests or showing something interest his caregiver. Then other important thing, the child development in early toddlerhood is social referencing. Here, child look for cues from caregiver when encountering something new. He studies the phases of for cues. He react according to the input from phases of people around. When we see a child running around mall, still the child will be looking back for a non-person or caregiver. This means social reference, referring to the non-person before responding to someone new or stranger. That developed around 1 year. Then also this age, especially 1 year to 1.5 years, the child start meaningful communication. So many parents will come and tell that 1 year the child was start talking. When we ask in detail, then only will understand that meaningful communication not happen. Meaningful communication is not babbling, simply telling Baba, Mama. but it is for needs and for demands, they have to call the non-person. That by kinship words and also functional words also develop in this age. Ao, Jao, all this comes in this age, and they identify the common object and name the common objects by 12 to 18 months. Then comes in late toddlerhood by 18 to 24 months. Then child also start communication to share the interest. We already described proto-declarative pointing or proto-declarative joint attention earlier, but it will be more evident this time. Then child will be showing the interesting pictures to mama, and so with that we have to look all the things I had told earlier: the eye contact, the child social smile, and interest to share interest. All this have to look along with this communication for sharing interest. Then as a whole, in a simple development surveillance that should happen in every visit, and or we can even dedicate all vaccination visit as for development surveillance, and at least 3 visits should be there for developmental surveillance, where it happen 9 month, 18 month, and 24 to 30 month. So you should look at for the all red flags and focus the history and examination, and it can pick some of the early signs of ASD. So development surveillance should happen in every visit, and at least it should happen in 9, 18, and 24 months. And vaccination visit will be the best time, because child will be happy. Because while a baby is sick, it's very difficult to assess the social communication as such. So with this, I'm concluding, and next talk is on developmental screening.
Thank you, Dr. Shafi. Next, Dr. Anjala Lakshmi will talk about office-based developmental screening in autism. After completing her IAP fellowship in developmental and behavioral pediatrics from CDC Trivandrum, she is currently working as an assistant professor in the Department of Pediatrics at SUT Medical College, Trivandrum. Welcome, Dr. Anjala.
Thank you. Am I audible? Am I audible?
Yes,
Yes,
you are.
Okay. Please let me know if there is any technical problem, because as Dr. Indu might be already knowing, I'm not that good in technical side. Okay. Good afternoon, respected seniors, colleagues, my dear friends, teachers. I'm rather excited to see many of my teachers and many of my co-fellows in this platform today. So without wasting much time, I would like to start with my presentation. I'm extremely humbled to be given this opportunity. I will be talking about certain screening tools. And can I have my next slide, please? We all know that autism is a neurodevelopmental disorder, and it has disturbances in social communication and social interaction, and associated with repetitive behaviors and restriction in the range of interests. Okay, we all are aware of it. This is a diagnostic criteria of autism spectrum disorder. And can I have my next slide? IAP recommends screening for all children at the age of 18 months and 24 months. So as my topic itself is suggestive of screening tools, I would like to talk about 3 screening tools in this short period of time. That is Concern 9, MCHAT revised with follow-up, and Trivandrum Autism Behavioral Checklist. So number 1 is Concern 9. As the name suggests, it has 9 questions that can cause concern to the mother or the primary caregiver. Dr. Shafi has already told us about surveillance and certain red flag signs. In a way, we are actually taking some of the red flag signs and putting into this tool. It is a 9-item red flag sign that can be used for identification of autism spectrum disorder among toddlers between 12 to 18 months. And it has an excellent diagnostic accuracy. Cutoff score of 2 or more items gives a sensitivity of 93%. Can I have my next slide? Yeah, this is the actual questionnaire. You can actually see there are 9 questions regarding, most of these questions are actually red flag signs, in fact, and the mother or the primary caregiver will be given this questionnaire and will be asked to score whether it is yes or no. If it is yes, it will be given a score of 0, and if it is no, it will be given a score of 1. The baby is showing interest, or you can actually read through that. And if the total score is 2 or more than 2, there is some concern. The baby requires detailed developmental evaluation. And if the item number 7 is no, that is item item number 7, the baby is maintaining good eye contact with others. Suppose this item is coming under no. That is, the baby is not maintaining good eye contact with others. Even if the total score is less than 2, there is some concern. The baby has to be referred to a developmental pediatrician for further detailed assessment and intervention. And if the total score is 1 or 0, there is no concern. You repeat this concern 9 again at 14 months, 16 months and 18 months. I would like to bring your notice that this can be done as early as 12 months itself. Not actually, the MCHAT starts at 16 months. We can actually try concern 9 at 12 months itself. Second, I would like to talk about MCHAT, Modified Checklist for Autism, revised with follow-up. This is the evergreen screening tool that we use for autism spectrum disorder. This is a 2-step parent completed screening tool. It is available online. Anybody can freely download it and anybody can use it. There is a small, user manual kind of thing. Anybody who can read and follow the instructions, it is very easy to use. It has 20 questions again, requiring yes or no answer. The typical answer is yes in all the items except 2, 5 and 12. Question number 2, question number 5 and question number 12, the expected answer is, or the appropriate answer is no. All the appropriate answers are scored as 0 and inappropriate are scored as 1, and you sum up all the scores. That's it. And next slides are actually put up all the 20 questions, and those of which are underlined in blue or marked in blue are the questions which I told. Have you ever wondered your child is deaf? The appropriate answer should be no. And does your child makes unusual finger movements near his or her eyes? Again, the appropriate answer should be no. And then question number 12, does your child get upset by everyday noises? Of course, answer should be no. Like that, there are 20 questions, and it is, you can actually, it is, yeah, this is the form, a follow-up scoring sheet. This is a follow-up scoring sheet actually. We can actually freely download it from the net, and with the help of little bit practice, we can use it. Can I have my next slide? Yes, this is a scoring sheet. If you get a score of above 8 to 20, you have to refer to a developmental pediatrician for an in-depth evaluation. Believe me, this is just a screening tool. We are not diagnosing autism spectrum disorder. We are just screening. So we feel this child is having high risk. So 8 to 20, any child who is having a score of somewhere between 8 to 20, immediately you refer the child to a developmental pediatrician for an in-depth evaluation. Any child who is put under a score of 0 to 2, you continue developmental surveillance, as the prior speaker, Dr. Shafi, has told, developmental surveillance. And somewhere between 3 to 7 is the gray zone. You counsel the child, you counsel the parents, and you follow up the child using the follow-up form after 1 month. Okay. Now, when the child comes for follow-up, you have at medium risk, the items that had inappropriate scores in the initial test are actually revisited, and the responses that remain inappropriate are now given the nomenclature of fail or pass. If 2 or more items are fail, the screen is positive, means the child may be having a risk of ASD, and you refer the child for a detailed evaluation to a developmental pediatrician. This is supposed to be filled by parents and scored by a pediatrician. Okay. Now, the last part, the last tool, I would like to talk about Trivandrum Autism Behavioral Checklist. This is again from CDC Thiruvananthapuram. This is again a screening tool using 20 questions. 20 questions are actually put into 4 domains like social interaction, communication, behavioral characteristics, and sensory integration. The parents are asked to score this based on the intensity of the behavior. Never, sometimes, almost, and always. Based on that, we'll giving never, sometimes, often, and always. We give a scoring system of 1, 2, 3, and 4, and then we total it up. If it is somewhere above 44, the child is at a high risk of developing autism. If it is somewhere between 36 and 43, it is mild to moderate, and 20 to 35, the child is non-autistic. So in this short span of time, I think I have told little bit about 3 tools, and these are the 2 references for TABC and Concern 9. Concern 9 was actually published in 2022. If anybody wants to read up more on that, could probably use these references. Thank you.
Thank you, Dr. Anjita. Now we have Dr. Shailaja Srijit talk to us about the common parental concerns in autism. Madam did her IAP Developmental and Behavioral Pediatric Fellowship from NIM Spectrum under Dr. MKC Nair sir. She also holds a diploma in Learning Disability and Child Psychology from Singapore. At present, she is the Senior Consultant Developmental Pediatrician at Rainbow CDC at Anandapuri Hospital, Trivandrum. Welcome, madam.
Good afternoon, respected teachers and colleagues. So I'll be, first of all, I would like to thank my colleagues and the IAP chapter for such a wonderful initiative and giving me an opportunity. Okay, my topic is parental concerns in infancy and parental concerns in autism spectrum disorder. So in the infancy and early childhood, the earliest symptoms are not abnormal behaviors, but absence of normal behaviors. In early infancy, it will be absence of reciprocating expressions or social smile to the parent and looking at the parent's face, and absence of to and fro babbling. And most of the time, the child may resist cuddling. They may prefer to lie down, and they may not be showing any signs to be picked up. And overall, it will be like parents think my baby is so quiet and very good and undemanding baby. In the second half of infancy, it will be they may not be responding to the name call. And by 9 months, the peekaboo, the parents attempt to play peekaboo, the child may not be interested, and they may not be waving bye-bye, even if the parents try to stimulate them. And the gesturing, which comes at 1 year, the communication by gesturing, this will be absent. So because of all these symptoms, parents may, like in the developmental surveillance, the previous speaker said, the parents think there is some problem with the hearing loss. So some parents may be coming with a complaint that the hearing should be checked. And along with that, many children may have extremes of temperament or alarming passivity or marked irritability and crying. And at the second half of, later on, by the end of second year, maybe the child may start showing some languages, but there may be regression in at least some kids. Later on, at the second year and above, which is the symptoms of ASD are most commonly recognized, and speech delay is the commonest concern. This is the period of object naming, and so by even by 18 months, the child is not using any kinship words or not telling not calling parents like daddy, mama, and no requesting. Along with that, they may not be looking at the face, not very limited response to the parents' attempt to talk. There's marked lack of interest in other people. They will be interested more in solitary play, and they'll be in more on world rather than prefer to be in on world. And they may have poor play skills. They may not be playing with the toys like they prefer sometimes inanimate objects. So like earlier, they said the deficits in joint attention will be there. There may not be, the parents may come with the complaint that my child is not attempting to talk to me, no intent to communicate, and not sharing anything with them. And with that, there may be lack of adjustment of behavior, or we say meltdowns, according to the, they may be very cranky in a different new situations. And they, by this time, if you expand the lack of speech, there's no kinship words. By the end of 2 years, not connecting to words, and their vocabulary is very limited. And they may, for requesting, they may be using inappropriate means of communication, like leading the parents by the hand and going and standing near the objects. So overall, they will be, they may not be understanding the parents' talk, that is receptive language, and there will be delay in expressive language milestones also. And they may sometimes parents come with the complaint that the child has lack of attention. They think it is lack of attention and attention deficit hyperactivity disorder. Along with that, there may be difficulty in feeding, like many children doesn't chew food and very select high food selectivity. They may be disrupted, they may have interrupted sleep, and very difficult to train them for toileting skills. I'm sorry. So older children, we sometimes do come across older children who are not diagnosed before. They may again come with poor pragmatic speech, social use of language. And by this time, the children may be going to school and they may not be, they may not have the ability to make friends. And they may not know to communicate with the teachers with very limited interaction. And here, the social skills will be very less. So the teachers may ask the parent to go for a consultation. So we say sometimes they may be very aloof, or the behavior may be very weird behavior. So because of the poor perspective taking ability, they may have many inappropriate behavior and not keeping social boundaries. And they may have very limited vocabulary they may be still using functional communication only, no narration and poor use of grammar, and they may be very literal. They may not understand sarcasms, humor, and they will have difficulty to initiate maintaining or initiate a conversation, to maintain a conversation, and their speech will be, because of this, they may have very much difficulty in making social friendships. And they may have preoccupation with certain things. And because of the rote memory, we think the parents think they're fairly okay. But when the social interaction problem come, and they will come for consultation. And as we all know, along with that, they may the parents' concern will be the stereotypies, like the motor stereotypies, hand flapping, rocking or spinning, and the stereotype repetitive speech like delayed echolalia or idiosyncratic speech. And some of them may be very ritualistic, like they insist on the same way things should be done. And their interest will be very limited. Though they don't know the normal conversation, they may be an encyclopedia of something which is one topic, like Thomas Tank Engine or dinosaurs and all that. And they may have many sensory challenges, like to all the senses, like especially to sound or smell or tactile. It can be intolerance or sensory seekers. So in summarizing, the parents' concerns at the first 6 to 12 months will be infrequent eye contact, no name calling, not smiling, and emotional passivity or no reciprocity, and fixation on objects rather than on the face. And by 1 year, there's again no eye contact, no name calling response, and no body language or no gesturing. 16 months, there's not even no kinship words, no pointing or joint attention or social referencing. And by 24 months, no meaningful words or requesting skills. Or sometimes it may be loss of language or social skills. So suspect autism in a toddler with speech delay if they have no eye contact, unresponsive to name calls, and late talker, and always keeping himself, no sharing of interest, and stereotypic moments. Thank you.
Thank you, ma'am. Now we have Dr. Neelia Matthew. She will take the session forward, explaining about the time before the diagnosis, about how parents will help detect autism early. She is a developmental pediatrician at the Unit of Hope Center for Special Needs at St. John's Medical College Hospital, Bangalore. Welcome, Dr. Neelia.
Thank you, Indu, and thank you, IAP NDP, for this opportunity. So today I'll be talking about before the diagnosis, what parents can do, the parental concerns that can bring us to the diagnosis, and also why early detection is important. I think Dr. Shailaja has alluded to most of them, so I'm not going to go through all of it again, but a few things that I would like to add is sometimes they present with other complaints, and it could be a motor delay, it could be a global developmental delay, it could be tone issues, and it could be behavioral issues. And then we realize that this is looking like autism. Can I have the next slide, please? Yeah, so autism can be detected as early as 6 months, but usually detected around 4 years in Western literature. But I think in our country, we are seeing children even before 2 years, between 18 months and 2 years, we are seeing them. So by 2 years, we can make an easy diagnosis, but it's before that we may not be able to pick it up. They may be missed, or it might be hard to diagnose. Usually in early infancy, they may present with behavioral issues. A lot of children have sleep issues. When parents look back retrospectively, they say, yeah, he was very difficult. He just would not fall asleep. They may come with behavioral problems, with medical issues. So this was a study that was done in 2022 that looked into what were the parental concerns. And the initial concerns were mostly behavioral, followed by language development. Next slide. Yeah, so like I said before, autism is easily diagnosed by 2 years, but as early as 6 months, there can be subtle signs. And I just wanted to say, just like the children are on a spectrum, the parents, they're different kinds of parents. And one thing to understand is that each parent has a unique perspective. It depends on whether this is their first kid. Do they live in a nuclear family? Do they understand their child? They may understand the signs and symptoms of autism much earlier if they've already had a child with autism. So then they're more careful with the second one. Parents have their own dynamics, their own styles and approaches. A lot of parents we have seen, they have realized they are on the spectrum after their child has been diagnosed. So recognizing the parents' perspectives and their differences can help us understand and support families better. Okay, so when parents come to us, it is important, even when they come for a routine diagnosis or a routine vaccination, or they come to us with any concern, we should not wait and watch and tell them. I think this is the biggest problem that general pediatricians do. I don't want to blame general pediatricians, but a lot of pediatricians say, no, we'll just wait and see. We'll wait and watch. We'll see after 2 years. He will start talking. His uncle spoke late. Boys speak late. But these are things we should not wait and watch. It's always better to act early, because as evidence has shown, research has shown, we have all seen early intervention, early diagnosis leads to early intervention, which leads to better outcomes. And also this prevents, once parents know what is happening and we can give them that diagnosis, it prevents them from running pillar to post. We have had parents travel from all over the country searching for a diagnosis. And some children are then, as young as 2 years, are diagnosed with ADHD, started on aripiprazole, started on risperidone, which may not be required. Sometimes they're just diagnosed with a speech delay. And no one has committed to a diagnosis of ASD and counseling them and helping them to take it forward and guiding them where to go next and make a plan with them. So there's this really nice box on this side. It was a study done in the Netherlands where they were looking at the delay in diagnosis. So you can see there's parental concerns and there's professional concerns. The green box at the top is when there are no parental concerns, no professional concerns. We don't think there is any. This looks like a neurotypical child. This child will do well. Now we see box B. Now box B is where the parents have come with a concern, but the doctor says, no, it's okay. I don't have a concern. These children may be this child may have a delayed diagnosis. Then we see box A. The professional, the doctor or the therapist is convinced there is a problem, but the parents think their child is fine. He's doing well, he's good in his studies, and he's talking, and he knows the entire alphabet, and he knows all shapes and colors. But we know that these might be signs of autism. This child also may have a late diagnosis. Again, we may find then those red boxes, orange boxes at the corner. Those are also areas of concern, because the parent may have a concern, but if the doctor is not sure, again, we'll have a late diagnosis. Sometimes the doctor is not sure, but the parent is not sure, again, a late diagnosis. So what I'm coming to say by this is it's not just up to us. We need to have the parents on board. We need the parents to be aware, and we need to educate them, empower them, because only with the parents can we take this forward. So I think my biggest takeaway would be to the parents, to the doctors, to the general pediatricians, to the therapists, if you find that something is not right, it's always better to send for an assessment or start some early intervention, even if you cannot do an assessment immediately, because sometimes the waiting lists and the waiting times for assessment is very long. But early intervention has never harmed any child. Also, there's some cases which are a little harder to diagnose. Okay, so those are the ones that have good cognition, who are verbal, and sometimes girls also, because they may not have as many behavioral problems. Those children may also be diagnosed later. So I think as developmental pediatricians, we should also be aware about how girls differ from boys on the spectrum, and also look out for red flags in children with good cognition and who are verbal. Sometimes it's not there in the first meeting, but if you sit long enough, you might notice some quirks and some differences. So if the parents, because the parents know the kids the best, if the parents are coming with concerns, do not ignore, and do not wait and watch. Yeah, thank you.
Thank you, Dr. Neelia. Next, we will have our session on autism and AI, utilizing AI in early detection and diagnosis of ASD. I'm Dr. Indu S. Vishwanathan. I did my fellowship in developmental and behavioral pediatrics from CDC Trivandrum, following which I had a brief stint as a developmental pediatrician there. Currently, I'm working as a developmental pediatrician at Rainbow CDC at Anandapuri Hospital, Trivandrum, Kerala. So coming to the topic, what is the need for AI in autism diagnosis? As you know, the current gold standard of autism diagnosis is basically behavioral observation by a clinician using structured questionnaires and tools like ADOS, which is time consuming, and it only affords us the benefit of late detection, requiring at least a mental age of around 2 years for the kid to be diagnosed. So can autism be diagnosed with AI? Let's look at the role of AI in neuroimaging techniques, eye tracking technology, and genetics in diagnosing autism. So coming to neuroimaging modalities, can MRIs diagnose autism? Will autism show up on MRIs? So with the advances in AI, MRI has proven to be beneficial in a faster and objective early diagnosis of autism. You know the various phases of MRI. We have structural MRI, we have diffusion tensor imaging, DTI, which has already shown that there is disorganized microstructural white matter integrity within the autistic population. Then there is functional MRI, two kinds, task-based fMRI, which employs paradigms that map core symptoms of autism, like facial emotional recognition, response of a person to social stimuli across the various brain regions. Then there is resting state fMRI, which is mostly used for infants, toddlers, and those autistic patients who have poor language development, because they otherwise have difficulty performing tasks because of potential language barriers. So for such patients, we use resting state fMRI. But even though these different MRI modalities have shown a promise in distinguishing between the autistic individuals from healthy controls, the results remain inconsistent and non-replicable. Hence the need for neuroimaging biomarkers, which is an ongoing clinical challenge. But we have come up with computer-aided design systems, or CADs, which have succeeded in integrating these multimodal MRI with AI. So AI, or artificial intelligence, is basically replication of human thinking and problem solving using artificially intelligent components. A field of which is radiomics. Okay, so radiomics is a field that tries to extract and analyze quantitative features from medical images like the MRI. It goes beyond simply looking at the image visually. They try to use algorithms to extract detailed numerical information about the texture, the shape, and other characteristics of the organ we are looking at, namely the brain here. And radiomics uses something called explainable AI, which is AI trying to become more human friendly. It is related to the image data in such a way that can be understood by domain experts like the radiologist. So basically, within AI, we have algorithms like machine learning, which is a subfield within AI. And there is something called as deep learning, which is a further subset of machine learning, which makes use of specialized algorithms called artificial neural network, or ANN, which tries to simulate the human brain. An example of this is deep neural network, or DNN, which is an extensive network of artificial neurons which are capable of handling complex problems. Another one is convolutional neural network. So all these tools are able to perform feature extraction and classification. So using all these and combining it with MRI modalities like DTI and fMRI, multiple studies have come now. Okay, this is one example of a study in which the investigators try to investigate the accuracy of using computer-aided design system in autism diagnosis based on white matter connectivity. That is, they tried using DTI type of MRI. They concluded that there was a high diagnostic accuracy of around 73%. So the sum and substance of almost a lot of AI studies using neuroimaging, what they found is, like for DTI, they found there was altered fractional anisotropy and altered mean diffusivity in different white matter tracts and brain regions, along with micro and macro structural alterations in the corpus callosal integrity. Using fMRI, in the task-based fMRI, they found there was definite atypical activity within the social brain regions while performing social tasks, along with hypo or hyperactivation along different brain regions that are associated with different auditory and language tasks. And the resting state fMRI was more suitable for reporting altered brain activity in autistic infants, toddlers, and those with poor language development. And in them also, they have noted alterations in the default mode network, dorsal attention network, and salience network of the brain. Eye tracking is a non-invasive technique which tries to record a person's gaze position in real time. So eye tracking device is actually a high-resolution digital camera in combination with an intelligent algorithm like the DNN, using which the people have been able to study two-dimensional eye tracking scan path images, as you can see in the image above. Using DNN-based AI models, they've done the study and found they've achieved a cross-validated area under the curve of around 97% with an accuracy of 73%. So what this means is that this eye tracking is actually able to provide an objective assessment. There is no need for manual input by a person, unlike using questionnaires like MCHAT. And it can be used in babies as young as 6 months, well before autism-related behavioral traits start to manifest. And using advanced bioinformatics and explainable AI, they've been able to analyze gene expression also associated with autism. A meta-analysis was done, and they were able to pinpoint around 342 differentially expressed genes and around 14 high-risk SNPs, most of which were located on chromosome 10 and X chromosome. And explainable AI model also identified that MID2 gene is a potential autism biomarker. So in summary, in neuroimaging, both DTI and fMRI have been able to provide insight into an actual neural basis of autism. And using eye tracking data, we are able to have an objective early diagnosis of autism in infants as young as 6 months. And now we have a more comprehensive information on the genetic makeup of autistic population when combining studies with AI. Thank you. Thank you. Over to Dr. Sritama Chowdhury to lead you through the role of autism, AI in autism management. Dr. Sritama did her IAP fellowship in developmental and behavioral pediatrics under Dr. MKC Nair sir at NIMS Spectrum. Currently, she is a developmental pediatrician at Miracle Minds CDC at Bangalore. Welcome, Dr. Sritama.
Thanks, Indu, for passing the baton. And I'm going to take up a very interesting topic of how we use AI in autism management. Now, this is a fairly exhaustive topic, very elaborate. So I'll just be discussing on three major, I would say, advances in artificial intelligence in autism management as is used in the Western world. So the first application that I would like to discuss is called brain power. Indu, can I have the next slide, please? Thank you. So the brain power is essentially an AI system which is based on the modality of augmented reality or virtual reality. And it is integrated into a smart glass system. Like we see the Google smart glasses, which are now being used and in many engineering colleges in the Western world, and which is akin to Jarvis, as we know from the Iron Man series. So basically what the brain power system does is that it uses a technology known as the emotion recognition technology. It interprets our facial features and our body language into easily understandable emoticons or emotions that can be understood by children with autism. As we know, children and young adults with autism do face challenges in interpreting body languages and emotions and facial recognition. So what brain power does, if you can show the next slide, please, Indu. Yeah, thanks. So what brain power essentially does is that, as you can see here, the mother is smiling at the child who is diagnosed with autism. And brain power uses the AI technology to break down the facial features into a small emoticon like happy. Now, initially, this is being taught to the children as games. So the child essentially has to pick which is the correct emoticon in between two emoticons from the facial features of the person sitting in front. But as they go on progressing with the usage of the glasses and the system, they also learn to discern facial features and translate and understand emotions of the person sitting in front of them. Now, currently, this is still in the phase of clinical trials, but there is a case study which has been published on 2 children aged 8 and 9 years respectively that is easily available on PubMed, and I can share the link later if you want. So the next application I would like to discuss is called Social Minds Autism. And this has actually been invented or being used by a pediatrician who is also an autism advocate and the mother of 2 children with autism. So Social Mind Autism is an application which is based on pivotal response treatment, which is a specialized kind of treatment based on the principles of applied behavioral analysis. It is basically a personalized therapy feedback app. It works in this way that the parent is initially taught on how to give PRT using very simple self-paced interactive modules. After that, the parent clicks and uploads videos of a significant length, for example, say 1 minute length, of the parent interacting with the child and uploads it on the app. Now, the app uses an artificial intelligence system of understanding what the motivations of the child are, what the verbal or non-verbal communication practices of the child are, and how the parent is interacting with the child, how she is reinforcing or extincting a particular behavior. Then the AI app gives the feedback to the parents. And as you can see, this is actually a direct picture taken from the app. The app here is showing how the child is extending her hands towards the food as a mode of non-verbal communication, and how the parent can actually interact with the child, motivate the child to show more behaviors which are required and extinct the undesirable or challenging behaviors. So after the intervention period, the parent can again re-upload videos of them interacting with their child. And this goes on as a continuous process of feedback and improvement. Now, this app is still in its very early phases of development. It has still not been approved for clinical trials, but it's a very interesting way of seeing how therapy can be self-paced and can be delivered even without a therapist at home. So the next topic which I would be speaking about is a very, very interesting topic, which is social robots, something that is widely being investigated and researched on in the Western world. Now, what are social robots? So social robots basically are robots which have an interface that mimics human facial features, and they have an integrated AI system developed in them as well, which is for personalized user-based learning. It's often very similar to the WALL-E, as you know, from the very famous Pixar film. So WALL-E was not necessarily a social robot, but it's very easy to make out the emotions that WALL-E demonstrates by just looking at the binocular-shaped eyes. Now, how do social robots help children with autism or children with developmental challenges? Basically, it has been seen in multiple research studies that they can help in personalized management of children with autism by delivering therapy interventions, by assisting them in multiple challenging social situations, by helping, which may be as simple as finding their way around a hospital or school, or helping them cross the road, encouraging them to communicate, and most importantly, in today's world, filling in the need of a peer or a friend, as most of our children with autism and young adults with autism often face social isolation. The interesting point about social robots, which are being used for autism management, is the difference in the communication that the robot demonstrates. It has been found that when the robots use simple, repetitive, predictable speech models, which very concrete sentences, no idioms, no double meanings, they are very easy for children with autism to understand. Not only with autism, I would say children with other developmental challenges as well. And hence, the social robots can easily be used for management of these children. So some of the social robots which are currently being researched on include Cute Robot and Casper. As you can see, the interface is very human-like. And the other two robots, the next slide, please, Indu, which are specifically being researched on for children with autism include the Buddy AI project and the Matilda project. Now, we are still, and as Indians, we are still lagging behind when it comes to the use of social robots and other artificial intelligence technologies, because most of our AI technology is mostly based on food delivery and other apps. But if we really kind of delve into it, the use of AI technology and social robots can actually be used not only in management of children, but also young adults and the geriatric population who need care in social situations and who are often left without a person to give a caregiver or a particular home which can give care to them. Apart from that, there are also particular researches going on directed towards integrating robots with apps which can do behavioral analysis. And these help the robots kind of understand what challenging behaviors in children may be and give interventions and also ensure their safekeeping in challenging social situations. So with this, I would like to end my presentation, and thank you so much.
Thank you, Dr. Sritama. With this, session 1 has come to an end. Moving on to session 2.
Dr. Indu,
Yes,
thank you first and foremost, you and Dr. Sritama, for such a wonderful presentation. I take this opportunity to welcome Dr. Hemsagar, Professor Hemsagar from Nepal. Sir, we are honored to have your presence. I think we are showcasing our future leaders, but your presence gives us a very different level of boost. Thank you for your kind presence, sir.
Thank you so much.
I hope, sir, you would be enjoying the presentations. They are so informative and so practical. Just few words from you, the presentation which you just...
Sure. So far, all the speakers, how nicely they built up that topic on autism spectrum disorder. We started early recognition, their presentation in different developmental stages. And I was so fascinated with the topic of AI on autism. Honestly, I confess I have never heard of that details of use of AI in autism diagnosis and also in the kind of management. So I'm delighted. Do you believe me? I'm writing as well, a couple of things. I have a white paper in front of me and doing this. I found it really useful. Thank you. Thank you so much.
Thank you, sir. Thank you, sir.
Namaste.
Your kind words really gives us a great motivation. Thank you, Dr. Indu. Please continue. Great show, great activity.
Thank you, Dr. Indu. And with this, we move to our next panel. The next session too is going to be a panel on clinical case scenarios. And I would request Dr. Abhirani to start the screen sharing. And for this, we have Dr. Samir Dilwai, the National Fellowship Coordinator, who's going to be moderating the panel. We have interesting cases and how the autism can present in a clinical setting. And over to Dr. Samir for the panel.
So, Dr. Shambhavi, thank you very much. And it's been a wonderful afternoon so far with all lovely presentations. The next session is going to cover about the management. And we are going to cover it in 3 cases in the age-wise groups. The first group is below 5 years of age, then children between 5 to 10, and then children who present to us after that. And to begin the first case, each case will be dealt with 3 of our colleagues. And the first case, I invite Dr. Hema Nalini Kandru to present the first part of the first case. There are 3 cases, bear in mind. The first will be about an early childhood presentation. Dr. Hema is a developmental and behavioral pediatrician. She's from Ankura, CDC Ankura 9M Hospitals, Hyderabad, Telangana. And I'm very happy to say she's a very active worker for the cause, and she's the IEP, the chapter state coordination for Telangana. Dr. Hema, it's over to you.
Good afternoon, everyone. Thank you, seniors, mentors, and Dr. Samir Dalwai for the opportunity. The first case, 19 months old male toddler was brought by parents with concerns of inconsistent response to name and speech delay. Father's concerns were if it was because of vaccination or if this was virtual autism, as the screen time is around 3 to 4 hours per day. A mother was more confident that some children talk late, and he was saying Baba and Papa from 10 months and not responsive only during the playtime. The child was the firstborn of a non-consanguineous marriage with no significant antenatal birth, medical or family history. He was breastfed for 3 months, had feeding concerns. There was no delay in motor milestones. Next slide, please. So on observation, the child was found to have inconsistent response to name and was not giving an eye contact. Borrowed mother's hand to point to a toy. Play was solitary, both reported and observation-wise. It was repetitive. He was playing with a ring stacker, lining up blocks and toys and banging things. The anthropometry was age appropriate. Physical examination, there was nothing significant, and MCHAT scoring revealed a score of 11, suggesting high risk for autism. The age stasis questionnaire, communication, fine motor, problem solving were found to be below cutoff, and gross motor and personal social was close to cutoff. He had sleep initiation and feeding concerns, constipation, and there was no history of seizures. A provisional diagnosis of risk for autism with speech delay and sensory concerns was given. The parents were counseled, addressing the concerns that vaccination will not cause autism, and we have definite evidence from all over the world to tell that vaccination does not cause autism. Similarly, the virtual autism, there is no diagnosis as virtual autism. It mimics autism because of the delay in the social, cognitive, and language delay. Babbling, and we should not stop early intervention considering that this is what virtual autism. And parents do get confused between babbling and meaningful word. So according to Dr. Samir Dalwai, the word that has to be used is the IMP, which is interactive, meaning, and purposeful word. The social interaction and communication concerns should be explained to the patient, explained to the parent that the child is not able to interact and also communicate. The repetitive interests and sensory concerns are not helping with the play of the child and does not help the participation in any activities. The inform the risk of it being on the spectrum, and to the parents in an empathetic way. They need to accept that, and the support should be provided to the parents while giving the information that the child could be at risk, because it's not an easy thing to be handled by the parents. They should be assured that because they are in the early phase, the early intervention does help. Next slide, please. So the parental role would be to understand the child's concerns, educate themselves about what they can do for the child, train themselves regarding the behavior management and how they can look after the child at home and become the advocates for their children. The home, they should have a proper routine which will help the child to expect what is going to be the next step. The sleep hygiene measures should be in place. Physical activity is one thing that not many parents are involved into. So that aspect has to be looked into, and no screens have to be provided. Provide opportunities to play and participate. Participation in daily activities also is essential, and doing things along with the parents will help. Engage children in interaction, play and teach them turn taking by playing at their level, and involve them in all chores, which could be like kitchen work or laundry or everything possible, so that they learn, and parents should serve as models. And the aim would be to make the children independent and learn social skills. Parent-mediated behavior interventions help a lot, especially when we have a constraint in terms of therapy centers. So training parents in managing behaviors which mostly arise because of communication, attention, avoiding, and sensory concerns is essential. Early intervention at the right place, by the right therapist, for the right duration and follow-up is essential, and parents have a major role in that. Thank you very much.
Thank you, Dr. Hema, ma'am. The next part of this same case, early intervention, will be presented by Dr. Prafulla Srinivas. Over to Dr. Prafulla.
Good afternoon, everybody, and thank you, NDP chapter, for this opportunity. So, Dr. Hema has...
Let me just introduce you. He is Dr. Prafulla Srinivas, our colleague, developmental behavioral pediatrician. She is associated with the Spastic Society of Karnataka in Bengaluru, and she is a director of Gunasheel Axon Child Developmental Center, Bengaluru. Over to you for the next 5 minutes, Dr. Prafulla, to talk about how you will intervene in a 19-month-old child that Dr. Hema spoke so nicely about.
So Dr. Hema has left me with a 19-month-old child, and here we as Dr. Hema has put across all the features, this comes under at risk for autism. So what are the things that we do for at risk for autism? A lot was already spoken by Dr. Hema. She has already counseled the family. We want the family on board. Dr. Hema has mentioned about the importance of parent training, and in low resource settings where parent training becomes a very important way in which we can intervene for the child. So apart from those, other assessments which might be essential for this child would be a hearing assessment with the BERA, visual assessment, doing a detailed speech assessment, and other blood investigations, and EEG, genetic, and neuroimaging only if needed. Next slide. Next slide, Abhirami. Yeah, so why early intervention? So we all know how the neurodevelopment happens, and what is the importance of the sensitive period of brain development. So we have a 19-month-old child, and this is a very, very important phase for this child, who is going to go on to learn most of the gross motor, explore the fine motor, and the language development is the window period for language development is at this point of time. So we have to make the best use of the neuroplasticity, the neurodevelopment, include these aspects, let the parent know how important this phase is, and not wait to see some other maladaptive behaviors or further delay in the child's speech and communication. Next slide. So what do we need? So we need a center, and the center, we need the therapist in a center. The therapy unit has to be, the therapy program should be headed by a developmental pediatrician. The parent is a stakeholder. We have a physiotherapist, we have speech therapist, we have occupation therapist, we have the social worker, we have the psychologist. We need a multidisciplinary team to handle a child as young as 19 months. Yes, as young as 19 months, we need a multidisciplinary team to handle all those delays that we have come across. And for a child with at risk for autism, our aim is to address the core deficits, and the core deficits are in the ability of the child's communication, the child not playing enough, the child not doing many, or the repetitive behaviors, which is not allowing the child to explore all the cognitive ability of the child. So these are the core deficits that we want to address through a multidisciplinary team. And it has to be, for a 19-month-old, if I want the best outcome, it has to be a center-based therapy. Next slide. So as I mentioned, we need so many therapists, and we do a detailed assessment in domain specific, and we make a tailored, individualized plan for the child in terms of sensory integration, speech, gross motor, in how the child is playing or not playing, observing, keeping all these observations in mind. And I would like to point out here that if the child is having low speech or low communication, just speech therapy alone is not going to give us those outcomes that we want. The brain is growing holistically, and we need to address all of these deficits in a wholesome way. So I have had cases where the parents themselves choose only speech therapy because the child is not able to talk. So what happens to play then? What happens to the cognitive aspect of the child? What happens to the behavior, maladaptive behaviors of the child? So we need to consider a tailor-made, individualized plan, and we also need to understand that we have many models based on the behavior sciences that is there. And there are many therapists who most frequently or most well spoken is ABA, and a lot of psychologists are promoting only ABA. So will only ABA help a child with autism spectrum? Not really. We have to consider all these behavioral issues, consider the right behavior model for the child, and consider the therapists and their role in reaching our goal, a short-term goal to be set, a long-term goal to be set, and work for the best outcome for the child. Next slide. So one of the most frequently that we are following, most of us are following now, is the NDBI model, which is considering the developmental stage of the child, which is looking at the expected behaviors of the child for the age, and we are trying to work on the upskilling the child in the natural settings, may it be the home, may it be the school. So we want to train where the parent training model, or how we send school recommendations for the preschool that the child is enrolled in. So we want to work on all of these upskilling activities in the setting that the child is in, at home, at school, considering the behavioral issues, considering the domain specific delays, all of it. And we have to frequently follow up. So if I have started a program, I need to know, where have I reached? What is my goal that I'm reaching? What is my short-term goal? So we have to reassess the child frequently. And how much time, how much therapy hours will a child need? So this 19-month-old at risk for autism, we need a minimum of 20 to 30 hours of center-based therapy, and we need to follow this child up and do the right kind of assessments to understand what next and how to go forward. Next slide. Next slide. Dr. Abhirami, the next slide, please.
Yeah, I put the next slide. Dr. Prafulla, are you able to view it? Adaptive skills and inclusive education.
Yeah, so what is my aim? So this is my long term. The long term goal for any child is to be as independent as he or she can, and he should be able to educate himself. So these are my long term goals. So I set short term goals, and I reassess the child regularly. I work on, I also sometimes have to work on realistic goals. I may not be able to reach a particular goal in the way I have set or how the parent would want. So the long-term goal for this child would be to go on to have as much as adaptive skills that he can develop and work on, and to be educated in a inclusive school setup. Yes.
Thank you, Dr. Prafulla, for that wonderful talk. Continuing
Thank you,
with
Dr. Prafulla. I think you managed to summarize what is traditionally and conventionally being done for a child below 3 or 4 years of age as an early intervention. Of course, many of us may have their own differences and own way of doing things, but you've managed to summarize what is widely done across the world. Going ahead now, what happens to this child with all that Dr. Prafulla has described now? I invite Dr. Shubhi Verma, developmental and behavioral pediatrician from Indore, who's a consultant and founder of Enkindle Child Development and Guidance Center, was also associated with the Aurobindo Medical College and PG Institute, Indore, Madhya Pradesh, to take us ahead with this child. Dr. Shubhi, it's over to you.
Good afternoon, sir. Thank you for this opportunity. So for this child, now we have discussed the case itself and how we proceed towards the intervention part. There is a lot of buzz going around complementary and alternative medicine. So complementary and alternative medicine, or CAM, is divided into two parts, that is dietary intervention and nutraceuticals. But there is no conclusive evidence yet. A lot of studies have been conducted across the globe, and few studies have claimed that they have effect on the core deficits as well as sensory issues and behavioral issues in a child with autism, but still no conclusive evidence has been found. Also, a lot of issues have been discussed about the risk and the disadvantages of hyperbaric oxygen therapy and stem cell transplantation. It is currently not recommended as per IAP guidelines. So the camps are divided into 5 parts. One, those which have no benefit. Then there is possible benefit with potential risk, unknown benefit with low risk, possible benefit with low risk, and unknown benefit with potential risk. Now these all grouped together, they are still not recommended, and I would not suggest this child to be exposed to any of these medication. When we talk about psychopharmacotherapy, this child does not require psychopharmacotherapy since this child is very young. Also, this child is having a developmental trajectory where we expect development of autonomy and development of temper tantrums for this age group. So we'll tackle it with behavioral intervention or behavioral management first, and then go about it, manage the sensory issues and the developmental needs of this child. So for future of this child, what assessments we can project her to? So we have developmental quotient, which can be conducted using Bailey scale or developmental assessment scale for Indian infants, which will give us a good idea about motor and mental scales. Also, Mullen scales of early learning is a really amazing tool, which gives us intricate aspect of or intricate details of various aspects in development. While we talk about social maturity, we can use Vinland social maturity scale. For diagnostic purpose, ADOS is the gold standard. And the inclined diagnostic tool for autism spectrum disorder can also be used. Later on, when the child crosses 5 years of age, we can segregate it into mild, moderate, or severe autism based upon Indian scale of assessment of autism. And the behavioral assessment can be done by child behavior checklist or Vinland adaptive behavioral scales. And the sensory issues, we can subject the child to short sensory profile or sensory profile as such. Also, if we need to assess behavior and sensory issues periodically or quite often, we can use CBCL and short sensory profile as early as 3 months from the previous assessment. Now, with the future goals for this child, we have developmental quotient in various aspects as displayed in this slide. So we'll keep this as our base level and then work towards the core features or core deficits of autism spectrum disorder. What we need to do is monitor child's progress periodically after, I would suggest, every month in the initial phase of the early developmental period where we have picked up that the child is at risk for autism. And we'll plan her treatment and intervention regularly and change the goals as per child's developmental, behavioral, and sensory needs. Also, anticipatory guidance for caregivers is very important. What to expect next in the coming areas, what the developmental goals we have achieved in the successive goals or successive months, and then go about it. Thank you.
Thank you. I think Dr. Shubhi has concluded very aptly, and it's a good lesson and so much of learning for everybody. What is to be done going ahead? Dr. Abhirami, I'd request you to take over the next two cases. I'll be here in the background. Go ahead.
Thank you, sir. Thank you. Sorry. Thank you for the opportunity, sir. So the next case is case number 2. This would be for a middle-aged child, probably school-going child. We are discussing about autism in school-going children. So the case will be presented first by Dr. Ria Lucas. She is an IUP fellow in developmental behavior pediatrics under Dr. MKC Nair, sir. She is an associate professor in developmental pediatrician in Amala Institute of Medical Sciences, Trishur. And she has also co-authored and edited the Developmental Pediatrics second edition with Dr. MKC Nair, sir, and is a co-author for multiple articles at the national level. Welcome, Dr. Ria Lucas. Over to you, please.
Thank you once again. Thank you for the IEP NDP chapter and all the seniors for such a support. And we all the juniors are really thankful for your support and guidance, sir. Okay, so for now, after the first case of an 18-month-old child, we'll go on to the next level of case, that's a 6-year-old boy. Now, all of us, majority of us still deal with the children like who are exposed to screens or social isolations or younger children. And once in a while, or I mean, quite frequently nowadays also, like older children, like 6 to 10 years, they come, those who have been undergoing therapy. So this was a child, a 6-year-old boy who was brought by his parents with complaints of lack of expected improvement despite ongoing therapies. He was diagnosed at 3 years and he was undergoing therapies, OT, the BT, and the usual, the speech and everything under a therapist or the clinic or the developmental clinic. So I suppose all of you, we all have seen such cases who haven't been followed up by a developmental pediatrician. And the parental concern here was a limited progress in communication behavior. And the speech was still, he only used occasionally a few words, primarily with the mother. And usually it was a non-verbal communication, which the mother, for the past 3 years, she has been managing very well at home. She can understand what the child was meaning to do. And always remember that whenever a child comes to you first, the first and foremost important, what we have learned as pediatricians is the importance of history and clinical examination. And history-wise, we know that we have to concentrate on the antenatal, natal, postnatal history, the developmental history properly, and then the family history is not to be forgotten. So here there was a positive family history of development delay in maternal cousin here. And now on examination, on the history, like we use the development assessment. So he had a gross motor and fine motor age of around 3 years, but the language is poor. The social, he had on examination of poor eye contact. He does not respond to names, limited cooperation, no sustained attention with toys. He was seen to have certain visual stimuli like staring into space, and he has this repeated finger drumming and stimming. And in the OP, when we do a routine DDST or the Denver Development Screening Test, he is shown to have a suspect level in all the fields. And TABC, which is an easy screening tool that we can do in the OP till 6 years of age, and it showed moderate features of autism. So now, the next point that we want to ensure is when a child comes to you, all these features persisting on as the child is growing, 6 years, is not improving with much of therapy, what all should you think of? So here the physical examination. Now in physical examination, whenever you see a child, look for some dysmorphisms. So I know that many of us have some genetics exposure also. They'll be able to guide us more here. And here this child had a prominent forehead with a head circumference of around the 95th centile. There were prominent ears. He had a long narrow face with a high arched palate. And so dwarfisms, some are very obvious, like a Down syndrome. Obviously, we know, okay, this child is a Down syndrome. But Fragile X, all the features may not be very prominent as the child is young. The like macroautism and all the complete features will only be aware when the child is in the adolescent age group or the adult age group. And some other dysmorphisms, like if you have a Angelman syndrome or you have the ataxic gait or the Prader-Willi, all those have associated other features which make very easy for us to pick up. But some dysmorphisms may be very slight. So we have to keep our eyes and ears open. And again, the examination, the markers, look for neurocutaneous markers because you may be prone to be in a busy OP, we may forget to examine the child as a whole. So please always remember to examine as a whole. So look for cafe au lait macules, look for shagreen patch. And I remember like during our fellowship days, me and Shamal had a case where we found the shagreen patch and then we looked at the father, so he had seizure disorder and this child was a case of tuberous sclerosis. So look for things like that. And sometimes the history of seizures will not be very apparent to the parents. So the child may just have a staring episode or the lack of improvement might be something underlying some neurological markers. So look for seizures or any other metabolic problems that you should look for organomegaly or like always keep in mind such kind of simple things which we can pick up as pediatricians. And this child had no other neurological signs and no organomegaly. So I think the likely diagnosis obviously very obvious, autism spectrum disorder with mild dysmorphisms. So you should think of things like Fragile X syndrome and Peter associated disorders, and which I think my next colleagues, Dr. Rinki and Dr. Shamal will elaborate. And thank you once again. Thank you.
Thank you, Dr. Ria, ma'am. Sir, shall we proceed to the next? Okay, so I think we can.
Yes, go ahead.
Okay, so thank you. So the next same case scenario will be continued to talk by Dr. Rinki. Dr. Rinki Tandon is a consultant developmental pediatrician at Max Smart Super Specialty Hospital in New Delhi. She's the director of Creative Mind CDC in New Delhi. She's trained in Bailey 4 and has done multiple papers, posters, and research cases in the Indian Journal of Pediatrics as well as in IEP. She's a life member of the IEP, and she has also trained in sensory integration therapy. Over to you, Dr. Rinki. Ma'am will be talking about, she'll be continuing about the genetics behind this case number 2.
Thank you, Dr. Abhirami, and thanks to IAP NDP chapter for giving me the opportunity, and thanks to all the seniors. So I will be discussing on the management and intervention planning of this case. So all the children with ASD should undergo hearing and vision screening. And based on the family history, the examination, dysmorphic features, and presence of neurocutaneous marker, further evaluations are planned. So in the blood investigation, serum ferritin is done as iron deficiency is commonly observed in these children and it can lead to sleep disturbance and has an impact on the brain development. Then thyroid function tests to look for hypothyroidism, then tests for homocystinuria. So there are certain tests that are not indicated like routine metabolic screening except if there is a strong family history or if there is a history of if there is history of consanguinity or strong clinical suspicion in the form of seizures or if there is history of neuroregression. Then biomarkers, heavy metals, except the lead levels if there is definitive history of exposure. Then trace elements, micronutrients, and fecal microbiome analysis is not indicated. Food stamp examination for tuberous sclerosis if the signs suggestive of tuberous sclerosis are present like hypomelanotic macules. Then neuroimaging is indicated if there is abnormality in the neurological examination or the history suggestive of seizures, if there is neurodevelopmental regression or unexplained microcephaly. Then sleep deprived EEG, if there is a history of unusual spells or behavior which is frankly suggestive of seizures like irritability, head banging, aggression, or if there is significant regression in the language skills. Also need to rule out Landau-Kleffner syndrome, which is acquired epileptic aphasia with characteristic EEG findings, a continuous spike wave during slow sleep. Then genetic evaluation. There is no single mutation which has been identified which is unique for ASD. There is high yield of genetic testing in syndromic and autism plus, that is autism with comorbidities like intellectual disability or neurodevelopmental regression. Next slide, please. So there, after taking a 3-generation female family history and the detailed examination, if no syndrome is clinically identified, then all patients with unexplained ASD, especially boys, we need to do Fragile X screening. And also if there is family history suggestive of a male member with intellectual disability. So as in the present case scenario, also Fragile X screening, Fragile X syndrome is the most common genetic syndrome associated with ASD and has high chances of recurrence rate. Then chromosomal microarray is done in cases of idiopathic ASD. 9 to 10% of ASD children with idiopathic ASD have a clinically significant copy number variation, and that is detected by chromosomal microarray. Then all ASD girls with intellectual disability, we need to do mutation screening for MACP2. Then girls and boys with head circumference more than 2.5 standard deviation, we need to do P10 testing. If a specific syndrome is clinically suspected, we need to do targeted genetic testing like in Down syndrome, tuberous sclerosis, neurofibromatosis. If no syndrome is clinically suspected, then we do chromosomal microarray. If after history, examination, Fragile X screening, chromosomal microarray, no syndrome is identified, then we need to do whole exome sequencing to detect the single nucleotide variants. So genetic counseling is very important in ASD cases, as 25% of the children with ASD have an identifiable genetic cause. It is important for the families to understand that the genetic testing can give information about the recurrence rate, and it can give the cause of their child ASD, but they are not diagnostic of ASD. So if a positive etiology is identified, then counseling about the specific mutation should be done and associated clinical features, including comorbidities, treatment, and prognosis. If no etiology is identified, then the counseling about the recurrence risk is based on the sibling studies. So if one child is affected, their chances, 10% chances of recurrence in subsequent pregnancy. In case of 2 or more affected children, 30 to 36% chances of recurrence in the subsequent pregnancies. And genetic testing can be a life-saving option in other health conditions like monogenic syndrome with tumorigenesis like tuberous sclerosis, neurofibromatosis, and metabolic conditions where the correct diagnosis enable treatment and the prevention of health issues. So now coming on to the intervention, so the provisional diagnosis should be done before starting intervention by the multidisciplinary team led by the developmental pediatrician. So it should target the core features of autism. It should be evidence-based, structured, and based on the developmental and functional need of the child. As in the present case, the child was diagnosed as autism at 3 years of age and was taking therapies, but there was no improvement. So we need to look upon the individualized plan for the child, and we need to make a plan according to the developmental and functional need of the child. So this child needs behavioral intervention, also the naturalistic development behavioral intervention, which are done in the naturalistic environment of the child, then structured teaching, then along the speech and language therapy, using sign language or picture exchange communication system or speech generating devices like augmentative and communication devices. Then occupational therapy for the fine motor and adaptive deficit. Then sensory integration therapy is important in this case, as this child is having a lot of sensory issues. So then pharmacotherapy has already been discussed, and it is done if there is presence of specific target symptom or comorbid condition, and there is no role of complementary and alternative therapies. And casein-free and gluten-free diet is not recommended except if there is suspicion of gluten sensitivity or celiac disease. Thank you.
Very good.
Thank you, ma'am. Thank you, Dr. Rinki. That was wonderful insight into the intervention strategies that can be followed and the investigations that have to be done if a child, a 6-year-old or an 8-year-old comes to us with autistic features. So moving on to, we're continuing with the same case. We're having Dr. Shyamal Kumar, sir, who is an IEP fellow in developmental behavior pediatrics and a PGTTN candidate as well, student. He is currently, he's a state coordinator for the IEP NDP chapter of Jharkhand. And sir is going to talk to us about genetics in association with autism spectrum disorder. Over to you, Dr. Shyamal, sir.
Good afternoon, sir. Good afternoon, ma'am. Start with thank you for the opportunity provided. It's a big domain for me to present. Already a lot has been discussed about autism spectrum disorder perspective to the genetic aspect. I will just add on the few points. Till now, it has been documented and confirmed that ASD is a heritable disease. It has been proved through twin pregnancies where both the twins have been found to be affected, or in family histories where Dr. Rinki just mentioned that first chances of second pregnancy being affected with autism spectrum disorder is almost 9 to 14%. And third child, if two are already affected, it is almost 32 to 36%. So beyond doubt, it has been established that ASD is heritable. A little bit about the complex genetic architecture of ASD, which is thought to involve rare genetic variants where there are single gene which can cause a full spectrum of autism spectrum disorder. Until now, scientists have been able to decipher around 120 genes which are known to cause full-blown spectrum of autism spectrum. Beyond that, there are some polygenic variants, small defects in gene, which when present in accumulation will bring about the whole picture of autism spectrum disorder. Similarly, we see in diseases like hypertension and diabetes mellitus also. So there is some polygenic nature into the genetic architecture of autism spectrum disorder. Third, which I just want to mention, there are some epistasis, that is gene to gene effect, one gene affecting the expression of the other gene, and epigenetic effect, where the environmental effects are documented onto the gene. So these are three major effects which have been documented to cause full-blown features of autism spectrum disorder. Beyond that, genetic studies have made it clear that there are substantial overlap between features of autism spectrum disorder and other neurodevelopmental disorders, like we have seen a lot of cases ASD with ADHD, intellectual disability. Almost 15% will present with features of epilepsy also. And epilepsy has a bimodal presentation, one at 4 to 5 years of age and a second one in the adolescence. And obviously in adulthood or adolescence, schizophrenia can also present with autism spectrum disorder. So there are association between these features and autism spectrum disorder. Now, most common genetic syndromes associated include Fragile X, Rett syndrome, Down syndrome, Angelman. These are to name a few, but there are many which can be associated. So I will be discussing mainly about the two syndromes, Fragile X and Rett syndrome. One which will present as macrocephaly, that is the Fragile X syndrome, and one which presents as microcephaly, that is the Rett syndrome. So the Fragile X, why it has been named, we can clearly see that the normal X chromosome has this kind of picture, and the fragile side of the Fragile X syndrome has a additional, what I say is a NAB, which defines the structure of the Fragile X. Abhi proceed, just brush on. So this is the genetic architecture. I just wanted to, we know a lot about Fragile X. I just wanted to add on a few things So this is the CGG repeats which has been documented to cause fragile legs. Now, normally in a general population, the CGG repeats will be between 6 to 50. To be precise, it will be around 30 for a normal population. But once it is going beyond 55, so a range between 55 to 200 will be commented as pre-mutation. Why it is called pre-mutation? Because to go into a full mutation that is beyond 200, it has to go for a CGG count beyond 200. And what is the difference between the pre-mutation and the mutation is the FMR1, that is the Fragile X mental retardation 1 mRNA. So what happened? The expression of mRNA is abundant in the pre-mutation phase, while it is almost absent in the full mutation phase because of the methylation present. So though this pre-mutation will present with features of premature ovarian failure or FAXTAS, what we call it, the Fragile X Trevor ataxia syndrome. Here we will have abundant of proteins. While in Fragile X, there is a complete absence of protein, so the features of Fragile X will be prominent. Next slide. So the common clinical features, what we see in Fragile X is prominent and broad forehead, large ears, long face. Strabismus will be present in almost 15 to 20% of population. Prominent jaw and dental crowding will be there with high arch palate. Mitral valve prolapse because of significant height. Now height is there during the pre-adolescent and the adolescent phase, while during adulthood, the adult range of height catches up and the child will be in the average height during the adulthood. There is hollow chest also, hypotonia and joint laxity, scoliosis, and macroorchidism, which we commonly see. Now, I just wanted to add a little bit about macroorchidism, which is commonly associated with Fragile X. We do not see it in the pre-adolescent phase. It is commonly seen during the adolescence or the adulthood phase. And it can be clearly identified because almost the volume of the testis goes 2 times. So the normal average adulthood testicular volume is around 25 ml, and it goes about to 50 ml during in a case of Fragile X. So it can be clearly demarcated. And almost 80% of patients with Fragile X syndrome will present with macroorchidisms. Symptoms like autism spectrum disorder, intellectual disability, and distinct features are classical for Fragile X syndrome. Next slide. So the next presentation is on Rett syndrome. What is Rett syndrome? Basically, it is another syndrome associated with X chromosome. It is seen with girl child with ASD. The common mutation associated with the MECP2 gene, but it is not the only gene associated. There are other genes commonly associated with Rett syndrome is CDKL5 or FOXG1 has also been associated, but the bulk, that is the 95% of cases will have MECP2 gene mutation. It is in 95% cases, 95 to 99% of cases, it is a de novo mutation, and chances of recurrence in the sibling of an affected child is merely 1%. So here we can clearly see both the CDKL5 gene and the MECP2 gene, which are affected in Rett syndrome. So clinical feature of Rett syndrome is spread over the 4 domains. Stage 1, which will be presenting beyond 6 months of age, microcephaly, muscle hypotonia will be there, and that there will be delayed development. But the robust features of Rett syndrome will appear during the second stage, that is between 1.5 to 4 years of age. There is loss of motor and communication skill, stereotypical hand movements, the reading hand movement and watching of the hands classically seen with a child with Rett syndrome is present during this phase. Breathing irregularities will be there, seizures are there. Then there is worsening, regression of the head size. So there is worsening microcephaly, and definitely autistic features will appear. Stage 3 is the pseudo-stationary phase, where the features generally slow down a bit. They are progressing, no doubt about it, but they just slow down a bit. So there is potential cognitive and social improvement.
Wait.
Yeah.
Sorry. Oh, sorry. I'm sorry.
Okay, sir. Okay. So there is scoliosis present, seizures can be there, and autonomic dysfunctions can be seen. Lastly, that is the stage 4 or the late motor deterioration, decrease or loss of mobility can be seen, severe physical disability, dystonia, wheelchair dependency and Parkinsonian features during the late stage of the life can be seen. Thank you.
Yes, sir. Thank you, sir. Thank you, Dr. Shamal. So that was wonderful to talk about Fragile X and Rett syndrome in a short 5 to 6 minutes. To talk about both these genetic syndromes is quite difficult, but you were able to do it. Thank you so much, sir. Samir, sir, shall we proceed to the next case?
Yes. Well done, Ria, Dr. Kandan, as well as Dr. Shamal. Well done. We'll discuss later. Wonderful.
Yes, sir. So moving on to the third case, I will be presenting the third case. So I'm Dr. Abhiram Meenakshi, and I'm a consultant here in Chennai in Hamsa Kids Child Development Center. So as we see, as Samir sir had already mentioned, the first case was for an early infant. The second case was for middle childhood. The next case is for an adolescent child. So how does an adolescent present with autism? What are the challenges that we face? So let's say that we have a 12-year-old male child, and the chief complaints that he was brought with by the parents was poor attention in class and significant behavioral outbursts in school. So they were asked by the school teachers to visit a pediatrician regarding his behavioral outbursts. He had certain behavioral issues like head banging and self-injury when he gets angry. He started hitting others when he does not get his way. And he also has significant behavioral issues like disturbing others during class hours, which means that his sitting tolerance was quite poor. He was diagnosed at an age of 5 years with autism spectrum disorder by a psychologist. And from that point onwards, for over a span of, say, around 2 years, he has inconsistently gone just for speech classes. He has not attended any other therapy sessions. And the parents have seen only very minimal improvement. In the past 2 years, the behavioral issues have worsened, but some parents have been but in the recent 2 months, parents have come up with significant behavioral outbursts. So it was difficult for them to control the child, especially in the last 2 months. As I already mentioned, he has issues of disturbing others during class hours, as well as unable to wait in line for his turn, a lot of inattention and hyperactive behaviors. So when a DSM-5 criteria was done using the Inclin modified ASD tool, and he was satisfying the criteria for autism, as well as the DSM-5 criteria for ADHD. So in such cases, it is required that we do an IQ assessment as well for a holistic approach, and we do a CBCL as already mentioned. So IQ assessment would also give us an idea as to the current intelligence level or the cognitive aspects for this child. So what could have been done in such cases is, first of all, he was diagnosed at a late age, say around 5 years of age, where the neuroplasticity starts to slow down. And that he was not diagnosed by a pediatrician or a developmental pediatrician, but rather by a psychologist. Yes, psychologists are also important, but developmental pediatricians or pediatricians would have a better idea about this. So diagnosing by a professional like a pediatrician at an early age is very much important. And initiating interventions that are tailor-made for the child early on, that is also really, really important to remember. And performing investigations and genetic assessments, as already detailed explanation given by Dr. Shamal, Dr. Rinki, targeted therapy, all these things should be started early on so that we can catch the neuroplasticity and provide early intervention. So in these children, we should also understand about the comorbidities and what other forms of intervention strategies are available. For like younger kids, it's more of therapeutic interventions and goal setting and behavioral modifications. But for older children, we have to keep in mind the comorbidities as well as other pharmacotherapeutic measures pharmacological measures that can be taken. So I will be stopping my presentation here and moving on to Dr. Satya ma'am. Dr. Perma Satish, she'll be talking about comorbidities in these children that we have to look out for. She's a developmental behavioral pediatrician and she's the Tamil Nadu State Co-Coordinator. She's working at Rainbow Children's Hospital. Over to you, Dr. Satya ma'am.
Thank you, Dr. Abhirami, for the introduction. So, my sincere thanks to the AIP NDP chapter for the opportunity. Good afternoon, everyone. As comorbidities are very common in children with autism, and around 70% of children with ASD have at least one comorbidity, and around 40% will have around two comorbidities. So when comorbidities are diagnosed later or when they are missed, they cause a negative impact on the health, behavior, therapy outcome, and the quality of life of the kids with ASD along with the families as well. So it is very important that we look for comorbidities not only during the first visit, but during each visit. So, comorbidities in ASD can be either medical or neurodevelopmental, behavioral, or psychiatric comorbidities. So, coming to the neurodevelopmental behavior ones, ADHD is the most common one associated with ASD, happening in around 40 to 70% of children. And when ADHD occurs with ASD, it further compromises the social skills functioning of the child because of the inattention in social cues and impulsivity. And there is also increased challenges in inhibitory control, impulse regulation, and executive functioning of the children. And ADHD, as said by Dr. Abhirami, it's diagnosed by DSM-5 criteria. We also have screening tools like Incline ADHD, the Conners rating scale, CBCL, etc. Next slide, please. Yeah, the other comorbidities that are common are intellectual disability seen in around 45% of children, again diagnosed by DSM-5 criteria. And language disorders are also common, presenting as difficulties in comprehension and expressive phonology things. And anxiety is next common comorbidity seen in around 40% of children. And SCARE scale and Hamilton scale can be used for screening and assessing the severity, and diagnosis is by DSM-5. Depression, bipolar disorders, and eating disorders are also common comorbidities seen in these children. And eating disorders usually lead to nutritional deficiencies and poor growth due to the restrictive interest and the preferences of the child, eating patterns in the child. And other comorbidities are obsessive compulsive disorder, oppositional defiant disorder, schizophrenia, and self-injurious behaviors and aggressive behaviors. Next slide, please. And coming to the medical comorbidities, gastrointestinal problems are seen in around 10 to 70% of the children, and it's most common medical comorbidities seen in children with ASD. They can present with chronic constipation, diarrhea, abdominal pain, or GERD, and usually since ASD children have difficulties in communication and also sensory perception, they usually present with unexplained behavioral issues and sleep disturbances. So it is very, very necessary that we take a detailed history and complete examination, and if necessary, investigations. And sleep disturbances are the next common ones, presenting in around 40 to 80% of children, and they usually present with delayed sleep onset and decreased duration and frequent nighttime awakenings. The reasons could be melatonin imbalance, gastrointestinal disorders, and others. And we must always look for the underlying cause, treat the underlying cause, and we must follow the bedtime routines as well. And sometimes medications might be needed, which will be discussed later. And motor deficits are also common. They might be seen in around 70% of children, presenting as deficits in coordination, abnormal gait, or hypotonia. They have a negative impact in child's daily functioning, academic functions, as well as independence. The next common ones are epilepsy and immune dysregulation and genetic disorders, as discussed by Dr. Shyamal. So again, repeat, definitely look for comorbidities during each visit, because early diagnosis of these comorbidities will have a positive impact on the child's health, the behavioral issues, and also the therapy outcomes, and also the quality of life of the child overall. Thank you so much.
Thank you, Satya ma'am. That was about the so it was a well explanation about the comorbidities of associated with autism, especially seen in older children. Moving on to management of such children, of children with autism with ADHD, we move on to Dr. Nagashravani ma'am. She is a consultant developmental pediatrician at Apollo Cradle and at Vistara CDC Hyderabad. She is a clinical director at the Vistara CDC as well. Over to Dr. Shravani ma'am to please take up the next presentation.
Thank you, Dr. Abhirami. Good afternoon, everyone. I would like to thank all my teachers, seniors,
and my colleagues for this wonderful opportunity. So it's been elaborately covered till now, so I will try to be as brief as possible. So in this particular child, as we've already discussed, we require a holistic approach with a multidisciplinary team led by a developmental pediatrician or a pediatrician. And here, because it's an adolescent child with comorbidities, it would be better that we have a psychiatrist also in our team. And along with the whole team, we make an individualized education plan depending upon the current child's strengths and difficulties that he is going through, which would be including comprising of the sensory motor therapy, OT, PT, special education, the speech therapy, behavioral therapy, which focuses because he's having a lot of behavioral issues, violent behavior. Here we try to understand the cause behind that. Is there any sensory triggers that he is going through, and are there any habits that have been formed? So, and given calming down strategies and emotional regulation methods, so which would be much more helpful for the present child. And taking the age into consideration, it would be good that we look towards the vocational training also, depending upon the IQ of the child and other assessments and what information that we have got. And here, rather than only the therapies, it would be much more better that we work in all the areas of the child. So particular child, if he's interested in music or if he's interested in physical activities, thinking about that, we can nurture those skills and try to look into the extracurricular activities like art, swimming, cycling, yoga, and how can we make that part of the child's day-to-day routine where it will be helpful to make his strengths become much more, and taking account of his interest and what are the needs that he is going through. And coming to the last one, which will be the most important one in this scenario, taking into consideration an adolescent child with comorbidities, it would be the psychopharmacology. So before I go towards, Abhirami can give the next slide.
Sorry. Yeah.
Yeah. So before I go to the medications part of it, there are a couple of principles that I want to just highlight. So when should the medications be used? Most commonly used above 6 years of age or an adolescent age group with the comorbidities of ADHD, anxiety, or depression. And if at all, always we should understand that this should be with along with the therapy, not it is not a substitute for therapy. And when there is a suboptimal response with the regular therapies which are happening and with the comorbidities which has been identified already, this would be much more beneficial like an add-on therapy. And coming to, it's always better to use as much as possible to use FDA approved medications for that particular diagnosis. And coming to few of the principles, use as few psychotropic medications as possible. Always use it one after the other.
I apologize. 1 second.
Sure.
I think some edit. Sorry.
Yeah. If it's okay, I'll just continue with it.
Yes, yes. Now it's okay.
As I was telling, let us always think twice before we start the child on psychotropic medication, and preferably always start in a sequential manner so that one drug first started at a very low dose and see the response, the optimal response that we reach, and keep a very close watch of the side effects and the other monitoring that we have to require for that particular drug, and then take a call and slowly escalate to a correct balance between the optimal effects and the side effects. And coming to the next thing, where I'll be talking very briefly about commonly used medications. Coming to ADHD, you have stimulants and non-stimulants. In stimulants, methylphenidate is a commonly used medication. So here what we need to understand is only ADHD alone, stimulants have much better response than when it comes to a coexisting diagnosis with ASD or a comorbid condition where ASD and ADHD are present. Stimulants may be helpful like 30 to 40% of children. So we need to have a much closer eye when we are starting in a child with ASD. So in methylphenidate, again, you have different preparations. You have a short acting, medium acting, a long acting, extended release, depending upon the requirement of the child. And we always start with a low dose of IMG once a day and slowly titrate it into maximum dose that we can give is 60 mg. So here, what we need to be monitored or be careful about is always rule out any pre-existing heart conditions, any family history of heart conditions are present, and always check the baseline heart rate and BP of the present child. So that after you start the medication, you can just monitor those things so that we try to prevent any unforeseen side effects. And always remember in this, you may have appetite suppression and sleep difficulties also. So monitor their growth and development also. And coming to the other one, non-stimulants, you have selective norepinephrine reuptake inhibitors like atomoxetine, which can be used when the first line medication is not working out. So this is also used for ADHD in ASD. So here the major side effects that you need to be very worried about is there is a high chance of suicidal tendencies. And coming to, you have something alpha-2A adrenergic agonist like clonidine, which also can be used as an adjunctive treatment with the stimulants for ADHD with ASD. And coming to the other part of it, you have antipsychotics, which you can use for irritability in autism, maladaptive behaviors, or a violent outbursts in children with ASD. So here you have risperidone and you have aripiprazole. So risperidone is most commonly used that all of you guys must have come across. So the usual the doses, you start at a very low dose of 0.25 to 0.5, you can go up to 3 mg in a day. You slowly titrate depending upon the response and the side effects. So here the common side effects that you need to look for is sedation, weight gain, insulin resistance, tardive dyskinesia. And here we need to also understand that we need to monitor the metabolic profile. So monitor the weight of the child every monthly, and you may have to do the metabolic workup 3 to 6 months once, depending upon the clinical features. And coming to aripiprazole, if risperidone doesn't, because of any of the side effects we're not able to give, aripiprazole is a good option, which we can give in this kind of a scenario. And the last medicine that all of you guys must have used is melatonin, which we use it in sleep disturbances. Here the dose would be 1 to 3 mg, and you can go up to 5 mg without much of the side effects. The only side effects that you need to be careful about is long-term use can cause a suppression of the hypothalamic axis. Thank you so much.
Thank you, Dr. Shravani. With that, we come to the end of the third case. Dr. Samir sir, over to you, sir.
Dr. Samir, is he there?
Dr. Samir?
Samir sir?
Should we move ahead to the next session?
Just a minute. I first and foremost congratulate all the real learned, I would use the word, genuine learned speakers who made the case scenario so interesting, so practical. The best part is the application should be such that we are able to apply in our clinic practice. I always feel presentation is one part, but applying those things in our day-to-day practice is what should be the aim, and I think that was very well covered. I take this opportunity to welcome Professor Ehsan, the President of South Asia Neurodevelopmental Behavioral Pediatrics from Pakistan. Sir, we are honored to have you. This is a great experience for all of us, where our future leaders are delivering fantastic talks. I think you are listening. We need to have your input, sir, and we really thank you for taking time out and joining this great effort of our chapter and our young leaders from our chapter. Professor Hassan, sir, President of Sanbepa South Asian Neurodevelopmental Behavioral Pediatrics Association. Sir, please unmute yourself. Just a few words of encouragement from you. Sir, you are muted. Okay, then. I think there's some technique. Please continue. We'll have sirs. Sir, can you listen to her? Yes, sir, please.
एहसान सर बोलिए
वीडियो कॉल
I think we continue, Dr. Samir. Dr. Abhinay, please continue the next
I think
session.
he's facing some network issues. But
Yeah.
Yeah, Dr.
Please
Ehsan,
continue
can you
with the next
unmute
session.
yourself? Dr. Ehsan, can you unmute yourself? All right. I think till he unmutes, I'd like to say that we had a lovely presentation by 9 brilliant youngsters who are our alumni and for our fellowship, who've been trained very well by their coordinators in their respective institutes. And you could see that within 5 minutes to be able to cover up such important topics. And we had 3 cases which covered the entire gamut of presentations to us. A child below 3 years of age, some middle-aged, as well as an adolescent child. And as we realized, there's no one particular way of really saying this is the right thing and wrong thing. My only message to all the youngsters would be, don't get rigid about any one particular method. Keep thinking and keep evolving. Abhirami did a great job coordinating all this. To have 9 speakers in 1 hour and yet doing a good job and fair job is not very easy. So Abhirami, thanks to you and to all of you who participated. Thank you very much.
Thank you so much, sir.
So with this, I think we move ahead to the next session. That is the third session. Thank you, Abhirami, once again for the wonderful execution of this last session. And for this third session, Beyond Childhood, Adolescent and Adult Autism Care, I would invite Dr. Harshita to take over as the host. Dr. Harshita?
Yes, ma'am. Thank you so much for the opportunity, ma'am. So now in the third session, we have Beyond Childhood, Adolescent and Adult Autism Care. So the first speaker would be Dr. Nilanjan, who's going to talk about transition planning. He's a developmental pediatrician from Agartala, Tripura. He has done his IAP fellowship from Sedu Child Development Center, Goa. Over to you, sir.
Thank you, ma'am. Am I audible, ma'am?
Yes, sir.
Thank you, and very good afternoon to all of you from the northeastern part of India. I would be talking about transition planning beyond childhood. We had some very good case discussions as well as topics on how autism presents in childhood. Let us now look at how autism presents in adulthood and how we support them during adolescence. So the transition from childhood to adolescence is actually a very demanding one. And it's not that only the child is involved, but it also involves the families also. And whatever research was done, it suggests that compared with peers without autism, children with autism had high rates of unemployment. They had low participation in education beyond high school, and majority of them continued to live with their family members or relatives. And almost nearly 40% of them had limited opportunity for community or social activities. Next slide, please. Now, what is the importance of this transition? So the transition from primary to secondary school is a major milestone in the life of a child. And as we all know, the structure changes from primary to secondary school. It is earlier a play-based sessions which goes on, and now it's more complex organizational structure. Moreover, the subjects are new, the subject teachers are new, the way the teaching methods differ from teachers to teachers, and there is a change in routine as well as the classroom, for which there has to be a timetable which the children should follow. Moreover, there are higher expectations of independence from the child at that time. And the focus of intervention planning shifts from the addressing the core deficits to promoting adaptive behaviors. Also, we must know that it coincides with adolescence during this period, and all the biological and developmental issues that accompany puberty affects the child at that time. Next one. Also the sense. Previous slides, no? The secondary schools, being physically big, noisy, and chaotic, can be very overwhelming for people on the spectrum. And change can be stressful. Previous slides, ma'am.
This one, sir? Which
Previous
one, sir?
slide, ma'am.
Previous slide.
Can you hear me?
Yeah, yeah. Do you want the next slide,
Okay,
sir?
fine. So I'll start from here.
Okay.
I'll start from this slide then.
Oh.
So how to develop a transition plan? It's a great idea to prepare teenagers. Our plan is to maximize the likelihood that the transition should be successful. And it's a good idea to start planning early. This is because it
Can you see the slides, sir? Sir, are you able to see the slides?
No. Are you in the transition planning slide?
Yeah, developing a transition plan.
Yes, fine. Yes. So it's a great way to prepare teenagers. Our plan is to maximize the likelihood that the transition has to be successful. Next, every child with autism is different. And as we know, each child's transition plan should be different. And the plan should cover the education of the child, work, independent living of the child, social interaction, and also the community involvement. And we need to ensure proper communication to ensure a successful transition. Good communication between the professionals as well as involving parents in communication is considered to be critical. And we all know strategies should consider the unique needs of the child, and that involves sharing of information between the preschool and the post-school teachers. Next. So how do we make a transition plan? First of all, it has to be student-centered. Considering the child's voice in everything, we need to respect that child, and we need to know that this approach respects the children as individuals first. Next, we need to involve families, and holding transition meetings between families and the students is very helpful. Third, we can make a personal profile of the student where we can include the strengths of the child as well as the interests of the child, as well as the successful strategies which has worked in past for the child. Next, we need to do the school visits where it allows the child to familiarize themselves with the new environment and tour the facilities. Visual supports, as we all know, is a very good tool to help children with autism, and social stories can be very helpful in this regard. Next. School map. A school map of the new school is quite useful prior to any transition. The next slide. Social supports is another thing which we can do where peer buddies, mentor, either it can be older teachers or who can introduce the new student and can also assist in navigating the physical building. Safe space is a safe area where the student can go, and a safe person where the who can guide the child when the student is struggling. Teacher training about autism is very important. They should know about how autism presents in this age group, and we need to anticipate the obstacles. And the most important is we need to review and keep on monitoring the transition plan.
Sir, are you able to see the slides, sir?
Next slide, please. The conclusion part.
Is it visible, sir?
So to conclude, autistic children face, yes. To conclude, autistic children face more challenges during approach which we can do we need to identify the child's strengths and struggles. We need to establish a transition team. And as transition is a long-term process, we need to know that it is not a single-step process, and we need to conclude, I will just, I think the connection is not stable here. To conclude, autistic children face more challenges during transition, and there is no single approach to transition, and individualized plan tailored to that particular student has to be critical. And identifying the child's strength is very much important, and we need to establish a transition team between the family and the school. And we need to know that transition is a long-term process, and successful transition will depend on. Thank you.
Thank you, sir. Next speaker will be Dr. Harshita, who is a consultant from Christian Mission Hospital, Madurai, and also working in AVSS hospitals. The next topic will be on vocational training. So why do we need vocational training? Following high school, only 10 to 50% of individuals are employed, and moreover, only 14% of severe form of ADHD children are employed. So the transition out of high school into the adult service system is one of the most vulnerable period. So the benefits of why do we need vocational training, which is defined as any type of job related training that raises an individual's productivity, and it includes learning in form of either a professional or a technical school program in training centers. So benefits of vocational training will be increase in job opportunities, increases their self-worth and self-esteem. It gives them financial independence, greater socializing skills and social integration, and it also helps them in having more opportunities to increase their quality of living. So there are different kinds of employment. There are day habilitation program, that is a daily activity program present in a non-residential place, which is not their home. The autistic adolescent is taken there and is given daily activities based on his work skills. Then we have sheltered employment, which is more often found in India, where place is accommodated only for the child with the benefits of the work skills that is given. And then we have integrated employment models. Under these, we have two types, that is supported employment and customized employment. Supported employment is where the autistic adolescent is taught some work skills and is given job-related work. In a customized employment, according to the work skill that is present, a job is invented for the case of the autistic adolescent, and they are then taught and given cut piece basis of money or wages are given. The last one will be self-employment, where an autistic adolescent is trained to start an entrepreneurial or a small business workshop, and then they are taught to how to run a small-scale business where the job opportunities are scarce. The next are the global models that are followed in vocational training. The first will be job coach model. Here we have under job coach model 4 models such as one-to-one model, mobile group model, group shared support model, and standard model. In this job coach, a professional is trained with an autistic adolescent to their workplace and constantly trains them. The second is by Dr. James B. Adams. This model incorporates the family, peers, friends, and occupational therapist and vocational training therapist. Here we have middle school, where first job skills are taught at home. Daily chores are given, a visual checklist is there, a job is taught and supervised, and then the checklist is replaced by prompts. Here they start learning the basic skills of vocational training. Then in high school, we have pre-job training, and the role of job coaches come here. Vocational rehabilitation is done. They will also volunteer They go to peer sites, mentors, vocational rehabilitation, transition counselors, and they are given different job trials. Here it allows them for a career exploration. The second will be post-secondary education. Their social skills are better, academic skills are taught, part-time work is given, and social networking is done. Here is where they learn the skills for employment, work experiences are gained. The most commonly found model that is in India, which is also cost effective, is the social and economic inclusion model. Here, step one will be at the age of 8 years, work skill assessment is done and they are categorized according to their work skill. And by 14 to 18 years, the step two, they are given training labs. The training labs can either be at home or at a workplace. At 14 years, they undergo individual transition plan as per individualized education plan. And by step three, they are given an opportunity in a community, like non-paid community placement by 18 to 22 years. Here, example, they can be given as a data entry worker in a municipal office where they're not paid, but they'll be supervised and will be given work experience. Step 4 will be job site training. Here we identify a peer model and they will take over the place of a job coach. They are a colleague that can be identified and who will help them to adapt to the environment. Step 5 will be supported employment that happens around the age of 25 years where they are successfully into the mainstream world where they work on a regular competitive world and they get to get their wages and can obtain financial independence. So what are the interventions that have been done in vocational training? First will be video models and video prompting. These are audio-visual displays which will be given for each task. Video modeling will be on completing one full task, whereas in video prompting, step-by-step skills are taught and then they are asked to complete a task. Then we have feedback, reinforcement by praise, behavioral skills training, computer-based instruction, and intervention packages. These intervention packages can either be single or multiple intervention packages. Video models and video prompts are most cost effective because in-house person or in-person need is not necessary, and then they are able to be more independent. So of all the 53 experiments that have been done in this review of literature, we have 100% positive outcome for agricultural tasks, 100% outcome in entertainment tasks, food services tasks, human services tasks, and clerical tasks. Thank you. Employment provides financial security and independence, which is also important for social networks of colleagues and friends. So the next topic will be by mental health challenges and support in autism spectrum disorder by Dr. Chandana, who is an assistant professor in Indira Gandhi Institute of Child Health, Bangalore. Over to you, Dr. Chandana.
Thank you, Dr. Harshita. Good afternoon, everyone. Thank you to all my seniors and peers for this opportunity to speak in this symposium. So, the transition into vocational training and all has been covered by Dr. Nilanjan and Dr. Harshita. Today, I'll be exclusively talking about the mental health disorders. So, the incidence of mental health issues increases as a child transitions to adolescence and to adulthood. The incidence of mental health conditions is more in autistic individuals, and we have several studies done at different points of time which prove the same. It is also noted that it affects autistic children more than their neurotypical counterparts. Next slide, please. So comorbidity rates indicate that as much as 70% or more of youth with ASD experience significant mental health symptoms, and almost 40 to 50% of the youth meet criteria for 2 or more psychiatric conditions. This is according to a study conducted in 2018. So the incidence of different mental health disorders varies in neurotypical individuals and those with ASD. For example, the incidence of anxiety and depression increases in children with ASD, but the incidence of ADHD decreases with age, both in neurotypical individuals and in those with ASD. So the incidence of mental health disorders in individuals with ASD also varies with age. It is noted that adults have more incidence of anxiety and depression when compared to adolescents and children. Given the rapidly evolving evidence base, it is not clear which of the predictors of mental health problems are most important. Like, it can't be predicted if the temper tantrums in the younger age will lead to aggressive behavior, or it might lead to depression or ADHD. Additionally, it is difficult to deduce which predictors of mental health symptoms at a given point of time, as mentioned earlier, predict change of symptoms over time. So let's see the different mental health disorders seen in autistic individuals. Anxiety, depression, suicidal behaviors, inappropriate sexual behaviors, ADHD, OCD, bipolar disorder, schizophrenia, disruptive disorders, oppositional defiant disorders, conduct disorders, aggression, eating disorders, and disorders of elimination. It is to be noted that these behaviors stem from the core symptoms and they manifest as internalizing or externalizing. And they affect not only the individual, but also the people around them. So in autistic individuals, it is difficult to categorize behaviors into internalizing or externalizing. The line can be a little hazy. For example, if aggression in autistic individual is taken, it can be an external manifestation of a sensory issue or sleep problems. The sensory issue being an internal or the core symptom. Similarly, an inappropriate sexual behavior may be an external manifestation of deficits in socio-emotional reciprocity and communication skills. So let's see the causes of these mental health problems. It is very important to understand the interplay between autism and mental health, and it requires a holistic approach that considers unique needs, strengths, challenges in each individual. So, as mentioned earlier, these mental health disorders can be due to the core symptoms, such as sensory sensitivity, communication barriers, difficulties in transitions. It can also be due to social causes, such as lack of peer interaction, difficulty in adjusting to different social situations, causing social isolation and misunderstandings. It also depends on the efforts of the parents or caregivers and the attachment the child has with them. The features of school that they attend, the availability of social activities, their experiences while growing up, such as bullying, etc., or being included in a group, life events involving loss and separation, the level of functionality and independence. It can also stem because of intellectual disability or medical causes such as hormonal changes and epilepsy and other things. Next slide, please. So the diagnosis itself can be difficult in an adult or an adolescent with autism because it is a little difficult to recognize the symptoms, especially due to something called symptomatic overlap. The best example for this would be there could be social withdrawal in a child either because of anxiety or because of a core symptom of ASD. There is also a limited number of availability of validated tools for autistic people. So this results in variation in diagnostic procedures, the measures, and sampling differences. The challenges could also be due to loss of follow-up despite our best efforts and poor compliance to therapy. So the need for further study. There are very few studies with respect to mental health problems in autistic individuals of all age groups, especially in the Indian scenario. So with the recent rise in the incidence of ASD in our country, especially post the pandemic, recognizing these mental health problems and their appropriate management is the need of the hour. So longitudinal studies could help us better in doing so. So this not only recognition and intervention not only improves the quality of life in these individuals, but it also helps us decrease the burden of health on the government and society. Management. Management will be covered in detail by Dr. Arpita, but let's just see the core points. Targeted interventions and support systems that promote positive outcomes and enhance overall well-being for individuals on the spectrum. They should be engaged in meaningful activities They should be helped in pursuing their interests, fostering a sense of belonging within supportive communities. This nurtures the mental well-being and resilience. Tailored interventions. This is very important. And tailored interventions that address sensory sensitivities, social skill deficits, and help out with their executive functioning challenges. Establishing predictive routines and sensory-friendly environments offer stability and reduces triggers, especially for externalizing behaviors. Sensory integration therapy within CBT interventions, visual supports, visual schedules, social stories, social narratives, role-playing activities facilitate social skill development and promote successful interactions in sensory-rich contexts and reduce abnormal behavior. Considering that we as pediatricians treat a child right from the birth until they become an adult, there is always a sense of trust both the parents have and the child has. So it puts us in a very important position, which helps us to recognize all these mental health disabilities and to counsel the parents to help them what to look out for, and also to in helping them planning in taking care of the child or adult. Thank you.
Thank you, Dr. Chandana. Let's move on to the management part by Dr. Arpita. She is an associate professor from Vandam Mahavir Medical College, Safdarjung Hospital. Her special interest is neurodevelopmental disorders, autism spectrum disorders, behavioral issues, early child development, and intervention. Academic contribution: she has authored chapters in various books on normal development, developmental disorders, and behavior disorders. Part of IAP National Guidelines on Global Developmental Delay and Early Childhood Development, published multiple papers in national and international journals. Over to you, Dr. Arpita.
Thank you very much, Dr. Harshita, and I am really thankful to IAP, NDP chapter and all my mentors for giving this opportunity. I'm humbled to be a part of this great endeavor. So Dr. Chandana has already mentioned a very well described mental health challenges in these individuals, especially in the adolescent and the adult age group. And what are the main principles for their management? So when we talk about any mental health issue, especially in children with autism, so let me talk about these mental health issues in the past decades. So it was very less known, and because most of the studies which have been done are mainly on children, so there is very less data on adolescent and adults having mental health issues, and we actually need that, as mentioned by Dr. Chandana in her presentation. So it was seen that because most of the ASD was being diagnosed in those people who were verbally impaired, so it was seen that they did not have any mental health issues. But as we've seen now, that these individuals have verbal abilities and they can express, but their expression may differ because we all know that they do have a difficulty in explaining their emotional response and emotional feeling they are having. So most of them have this condition called as alexithymia. So one of the most important the way we can help these people with autism is having a good communication method. That is one of the major principle. Now, what is the alteration in communication method we can adopt for these individuals? We are doing it already for our kids, but for adolescent and adults having a communication problem, we can use a simplified language, which we are already, most of us are doing it, because we are directly communicating with the child or with the individual. We have to take care of their understanding of the emotional problem. So we may have to give them pictorial tools to understand what are they feeling, because we should understand that these mental health issues may not present, like anxiety may not present as anxiety, and they may have other features like aggression, frustration, irritability, compulsive feelings. So by giving those pictorial tools, we may help them by to understand their own emotional problem. We may talk in a very normal tone so that they can be able to understand that we are not judgmental, and we should not use any ambiguous language, because we all know that these children or these people, they take words verbatim. So by giving them very simple language, by giving them very non-ambiguous language, we may be able to help them to understand their feelings. Now, we can also use other methods of communication which may be comfortable for them, like using written text. That's it. Now, coming to the other problem, that is physical comorbidities. That is a very, very important reason why these people have mental health issues, and this has to be taken care of, as mentioned in the previous talks also. So because they may have other medical issues or underlying genetic problems, that has to be ruled out in each and every visit, because that may be reason why they have a compounded mental health issue. And if present, we should address that. A very important aspect is appropriate engagement with carers. Now, carers are not only important for taking care of the person with autism, but they are also helpful in telling us what are the problems that person is facing nowadays. It may be something which has happened, because of which he will be able to tell us the stressors for anxiety, depression in adolescent. It could be a school change, it could be a change of the hometown, or it could be bullying, as told by Dr. Chandana in her previous slides. So that would help us in understanding this, and we can also prime them for the therapies which we are going to use. Coming to the next point. Yeah, so the sensory environment is also an important part. So looking at that, because these people may have sensory issues which may compound their mental health issues, that also has to be taken care of, and especially in our clinics where we are seeing the child, where we are communicating with the person, we have to take care of all these things. Now coming to the next point. Yeah. So coming to the management part, it is a multifaceted approach. So we have to see both the family-centered and the person-centered. We have to also include, the first step we have to include in this would be involvement of a psychiatrist, because most of the time we would need a pharmacological treatment. And the psychological and behavioral management remains a major cornerstone, and family has to be equally important. Please, next slide. So, yeah. Okay, so I've made a table so that we can see that most of the disorders, I've covered mainly 4, because I've seen there are a lot of studies which have reported that at least 2/3 of people, especially in their adulthood, they have anxiety or depression in autism. So that is a major comorbidity, and because these people may have alexithymia, they have emotional dysregularity, they may not be able to express themselves. So after communication, the psychological or behavioral therapy is the first line, and CBT is told to be the most important therapy, where we use it as a modified therapy, because obviously we cannot use CBT in all individuals with autism in a same way, because they have a different functional levels. So we have to first understand their functional level, their IQ, their severity, and then we have to modify the CBT accordingly. The CBT modification which is required is a structured approach with more of a visual aid use, more of use of the language which is simple, which we've already talked about, and incorporation of special interest of that individual, which may be helpful for increasing the therapy. The help of the therapy, it will be helpful for the child and for the individual for soothing themselves. So it could be use of computers, it could be use of any sport, it could be swimming, it could be anything, music, anything. So that is the first line, and it is the first line for mild anxiety and depression as well. The other pharmacological therapy which we use for anxiety and depression is SSRI. So FDA has approved use of escitalopram in individuals more than 12 years and in adulthood also, mainly for depression. For anxiety, use of fluoxetine is also considered for more than 6 years, but it has been seen that it may have both side effects also. So that has to be used in a great consideration. Fluvoxamine and sertraline can be used for children more than 8 years. So after using psychological and behavioral therapy, if there is a resistant case, we can go on to use these pharmacological medications also. ADHD has been covered very beautifully in the previous session. So the management is according to the general population. So ADHD usually in a adult or adolescent is treated by pharmacological management, and it has to be seen that ADHD if it is co-occurring with ASD, it may have other problems also like anxiety and depression, for which we may have to use other drugs and not stimulants, which may increase the symptoms of depression, bipolar disorder, etc. So that has to be used. And we have to also be very careful about other comorbidities like tics or the movement disorders, which may be compounded by the use of methylphenidate. We should also understand that behavioral therapy should go hand in hand, because that is something which we can use even if the pharmacological therapy is being given. And social skills therapy is particularly useful for all. It is not only for ADHD but also for anxiety and depression, which has been talked about already. Please, next slide. Okay, so schizophrenia is something which is less, and it has a very overlapping symptoms with ASD. So if we suspect that schizophrenia is there, the first thing is the person has to be referred to a psychiatrist. We cannot actually handle this, because this has to be treated pharmacologically, and treatment recommendation is similar to a person who belongs to general population, and we use the risperidone or olanzapine. So antipsychotic medications have to be started. Extra precautions which are included is that we have to monitor these people with blood test, and medical comorbidities like epilepsy or baseline cardiometabolic risk profile has to be seen. And there is no clear evidence for behavioral or psychological therapies. However, cognitive and rehabilitative therapies can be useful in some individuals. Coming to the OCD, again, SSRIs, particularly fluvoxamine and sertraline are very useful. And CBT, again, modified CBT is something which we can use. And exposure and response prevention is a technique of education, where some exposure is given, and the response prevention is the person is being taught how to prevent the response he's doing, mainly the compulsions he's following by some techniques. And another very important technique which is nowadays being used is mindfulness, and it is being seen that yoga, mindfulness, everything, these can be incorporated for all the individuals, particularly in even in children also more than 10 years of age, who are compliant to this, and it can help in decreasing mental health issues. Thank you.
Thank you, Dr. Arpita. That was elaborate. And now we have Dr. Kaveri, who's going to speak about legal rights. She works in Vistara Child Developmental Center, Kilpak, Chennai. She's the director of it.
Good afternoon. Legal rights is something that is very important and usually neglected topic. So I'm glad I get to talk about this. It is essential as a developmental pediatrician to know the legal rights and protections available in our country. These rights can help our children access healthcare, education, and financial support in a life of dignity and inclusion. So let us see the key laws that protect our children. We have the Rights of Persons with Disabilities Act, which has been a game changer. Then we have the Mental Health Care Act, the Right to Education Act, the National Trust Act, and the PWD reservation in government jobs and education. These are the key laws that are present right now. Next slide. So the Rights of Persons with Disability Act, why it's so important is it's because it legally recognizes autism as a disability, and it promises equality and non-discrimination and full and effective participation in society and access to inclusive education. There's reservation in education and government jobs for 4% of all disabilities. So We also have protection from abuse and discrimination, and there is right to reasonable accommodation and government schemes and benefits are also available. So the other entitlements under the RPWD Act are free and inclusive education for children from age 6 to 18. They also provide special educators and support systems in the school, and there should be barrier-free buildings and service to ensure accessibility, and reservation in higher education and government jobs. So what we mean by barrier-free buildings is that it means that we're creating spaces and systems that people with disabilities can access and use without difficulty. So for example, when we're talking about barrier free, like physical barriers would be providing them with the ramps and elevators, wide doors, and accessible toilets and such things. And communication barriers would be children should get visual schedules and simple language instructions and access to alternative communications if required. So these education rights under the Right to Education Act, you can move to the next slide. Okay, before this, I'll talk about the Right to Education Act. Here, the Right to Education Act says that every child has the right to free compulsory education from ages 6 to 14. And for autistic children, this would mean that there should be inclusive classrooms with the peer. There should be trained teachers and support staff. And there should be individualized learning plans where needed. And there should not be any denial of admission based on disability. The NEP 2020 also supports inclusive and equitable learning with flexibility and support for different learning needs. So when we come to the disability certificate and UDID, this is what is most important. And I think as developmental pediatricians, we should push our children to get this, because the disability certificate you can access most of the government benefits your child needs. And this certificate is usually issued by a medical board at government hospitals. For autism, the assessment is done using the Indian Scale for Assessment in Autism. The certificate confirms that the child has at least 40% disability, which is the eligibility threshold for benefits. And this certificate is usually reviewed periodically until they turn 18. So this is the first step to accessing your child's legal rights. Then we get the unique disability ID. Why we get this is because it's a national digital identity card for persons with disability. It replaces all paper disability certificates and is valid across India. The card also includes a QR code and a unique ID number. It simplifies access to schemes, concessions, and services. So every child with a disability should have both a disability certificate and a UDID. These are also needed for government benefits, school accommodation, concessions, UDI, and it also simplifies access to all the schemes and entitlements. Yes. So when we move on to the National Trust Act, 1999, this specifically covers autism, CP, intellectual disability, and multiple disabilities. These include insurance schemes like Niramaya, and they also provide sheltered homes and lifelong support services for our children. So for autistic individuals who require ongoing support into adulthood, they can also provide guardianship, which may be needed. Under the National Trust Act, you can also apply for the legal guardianship through a local level committee. This allows you to take legal and financial decisions on your child's behalf. Next. So what can we do as developmental pediatricians? So we can help identify and diagnose it early and support the documentation for disability certificate and guide parents through educational and legal rights and work with schools and therapists for inclusive care plans. I think by doing this, we not only help them with their development and other things, we also empower our children to live, stigma-free life. Thank you.
Thank you, Dr. Kaveri. That was very informative. Next, we have Dr. Vibha to talk about advocacy in autism, challenges, progress, and the road ahead. He is working as a nodal officer in District Early Intervention Center, North Goa. Over to you, Dr. Vibha.
Thank you, Dr. Harshita. A very good evening to everyone. Firstly, at the offset, I would like to congratulate all my seniors and the chapter for this wonderful initiative. And much thank you for providing me this opportunity. I'm going to talk about role of advocacy in supporting autistic individuals. And why advocacy? Because it is required, it plays a pivotal role in empowering individuals with autism, which focuses on their quality of rights and also protects their rights. Strong advocates, who can be advocates? Parents, teachers, or the individuals themselves, and they would work diligently to ensure that these individuals receive support and the resources they need. And all of us here present today are advocates for autism. Advocacy is essential. Why? Because our children or adolescents or adults with autism have to navigate complex systems like healthcare, education, and employment. Self-advocacy, being advocates themselves, is the best kind of advocacy because they would learn their rights, they would learn to express their needs and desires and make informed decisions about their lives. And how do we have self-advocates? We start by providing very, very early choices to children coming to us. We promote role plays, we promote independence in sitting in the IEP meetings, all that. So that is how we are going to have self-advocates when these children grow into young adults as well as adults. Next slide, please. Why do we require advocacy in India? Because we have certain challenges. Lack of awareness, social stigma, very late diagnosis and limited healthcare facilities. So maybe in the metropolitan cities or other cities, we may have diagnosis at an early age, maybe 2 years to 5 years. But in the rural areas, we are still yet a lot of work to do where diagnosis happens by 6 to 7 or even later years of age. A lot of educational barriers for autistic children. Most of the regular schools would say we cannot manage this child and please admit this child to a special school. So we have a lot of educational barriers as far as autistic children are concerned. And employment and social inclusion is still an issue for us because of rigid interview process, acceptance issues at the employment wherever these people are employed. So we have still issues with employment and social inclusions. Next slide, please. Next slide, please. What are some of the promising initiatives and solutions? The previous slide, Doctor. The promising initiatives and solutions and what is done so far as advocacy in autism is concerned. Increasing awareness, and our chapter of neurodevelopmental pediatrics plays a pivotal role in increasing the awareness. And in fact, one of the pictures I put up today is from the WhatsApp group where many members have put up several activities done during the autism month of April. Expanding healthcare and therapy centers, establishing district early intervention centers or regional early intervention centers in the country is a must. Inclusive education and special schools, where in an inclusive school where children are not segregated, but they're integrated, and we have an inclusive approach towards teaching the children. And employment and vocational training, I have put up a very interesting quote by Shruti Tandon ma'am, and she's a director of people's enablement. And she says that we realize that individuals with autism tend to thrive in an environment that is stable and consistent. And at our institution, we have made sure that they work with clients and on projects that do not change frequently. Whether or not they want to interact with the client has been left to their personal preference. So such kind of initiatives from policymakers, from managing directors of companies are going to go a long way in helping our individuals with autism as well as other neurodiverse needs. Next slide, please. What is the future ahead? Understanding the general population, understanding that autism is not a disability. It is a different way of experiencing the world. It is a different ability. Making autism screening mandatory, and we've had initial talks about autism screening, but it is still not mandatory in all the parts of the state. So we have, once autism screening is mandatory, we have early diagnosis as well as early intervention, training more and more doctors and as well as teachers in schools for managing individuals with autism, setting up more government funded therapy centers, and encouraging companies to adopt neurodiverse policies. With greater awareness, policy implementation, and community support, India can build an inclusive society where autistic individuals are valued, supported, and given opportunities to thrive. Thank you so much.
Thank you so much, Dr. Vibha.
Now, Dr. Hashi, I think I really congratulate each and every presenter who did great, I would say, justice to the topic. My only humble request is for all to just keep the time frame in mind. We are slightly running late, but great learning, wonderful presentations, great learning experience. Please continue.
Thank you, sir. So this is the final session. Session 4 is about clinical research studies. Our first speaker will be Dr. Jawahar, who's a senior resident and developmental pediatrician, Amla Institute of Medical Sciences, Thrissur, Kerala. Over to you, sir.
Thank you, ma'am. Am I audible?
Yes, sir.
Good afternoon, respected teachers, seniors, and my colleagues. First, I would like to thank NDP chapter for giving me this opportunity. Can you put that slide? Actually, this was a study. Ma'am, can you put the slide? Slide.
Dr. Hashi, the slides are not coming.
Okay, so one.
Sound also is low.
Am I audible, sir, now?
Yes, sir. Are you?
Hey, you're audible. The slides are not moving. You're audible, Dr. Jawahar.
Yes, sir. Thank you.
Are you able to see the slides, sir?
No, ma'am.
We are seeing the last presentation only, Dr. Hashi. Last presentation, last slide. Thank you slide is there.
Oh, okay, sir. 1 second.
Actually, this was a study.
Is this visible now, sir?
No.
No.
Harshita, can I?
Yes, ma'am.
Let me see. I can. You have to stop sharing your screen. Is it seen?
Yes, ma'am.
Yes. Just make it full screen, Dr. Indu.
Is it okay?
Thank you.
Yeah.
Yeah.
Yes,
ma'am.
please go ahead.
This is a study conducted during fellowship days at fellowship course at Child Development Center in Trivandrum during the time of 2020-21. The title is Impact of COVID-19 Pandemic on Severity Level of Autism Spectrum Disorder among children aged 3 to 8 years of age. Can you put the next slide, ma'am? The aims and objectives are: aim is to assess the impact of COVID-19 pandemic on severity level of autism spectrum disorder among children aged 3 to 8 years. And the objectives are: first objective is to assess and compare the severity level of ASD among children aged 2 to 6 years attended Child Development Center group therapy using CAR score at 3 points. That is, first on time of evaluation, second 6 months after intervention, and third during COVID-19 period. Second objective is to assess and compare social quotient of children aged 2 to 6 years attended CDC group therapy using VSMS scores at 3 points. First on time of evaluation, second after 6 months after intervention, and third during COVID-19 period. And the third objective is to explore parental perceptions on management of these children during COVID-19 period. Actually, these children were initially assessed, diagnosed as ASD, and they were given this group therapy for 6 months. So initially, they were evaluated and assessed with CARS and VSMS. After that, they were given 6 months of group therapy, and they were reassessed. Those children were they were reassessed during the COVID-19 COVID period. Ma'am, next slide. Ma'am, can you put the next slide? Ma'am, can you put the next slide?
Yeah,
Next
actually,
slide.
just a minute, it is stuck somewhere again.
Okay.
I'm not able to escape also. Okay. I think I'll have to scroll it.
Yes.
Yes.
Yes, ma'am. The methodology study design, it was a hospital-based cross-sectional study. The study setting is that a study was conducted among children with ASD attending therapy at ASD clinic in Child Development Center at Trivandrum. The study population were children with ASD below 7 years of age who were attending group therapy session at CDC during pre-pandemic period and their parents. Those were the study population. As I had told earlier, initially all these children were assessed and diagnosed as ASD and they were given 6 months of group therapy at CDC. After that, they were reassessed with CAR score and VSMS. Those children were called back during COVID pandemic period and they were assessed again. The study period the data were collected by principal investigator between February 2021 to August 31st, 2021. That is 6 months duration. Sample size was taken as 60, but we obtained only 34 samples. Study tools were Childhood Autism Rating Scale and VSMS, Vineland Social Maturity Scale. The results were, ma'am, can you put the next slide? Results and conclusion. The CARS assessment showed statistically significant decrease in severity of ASD after 6 months of group therapy and subsequently during the COVID-19 pandemic. Evaluation was 34.96 with standard deviation of 3.65. And after 6 months of group therapy, the CAR score decreased to 31.34 with standard deviation 4.48. And these children were reassessed during COVID-19 period. That was those time CAR score was 30.21 with a standard deviation 4.67. All the items in the cars have statistically significant difference in scores depending on the time point, except adaptation to change and taste, smell, touch, response, and use. The mean VSMS social quotient differed statistically significant between time points. The VSMS score, the social quotient score improved from pre-intervention to post-intervention, but from that, it decreased from post-intervention to COVID period evaluation. The mean score, social quotient first at the time of evaluation was 65.76 with standard deviation 14.74. After 6 months of group therapy, the score was 72.12 with standard deviation 17.27. And during COVID-19 period, it was decreased again to 66.42 with 17.88. And the majority of the parents reported behavioral problems for their children during COVID-19 period. The limitations of this study was estimated sample size could not be achieved due to regional lockdowns, all those things. And this study was conducted for a short-term impact of COVID-19. And these comorbidities and medicines used by the children were not taken into account. And the strength of studies during this we have done during this COVID-19 pandemic, and this study was done with a direct face-to-face assessment with children during that COVID-19 period. That was the strength of the study. Thank you. Thank you.
Yeah. Thank you. Harshita, this is the, okay. Having some problem in this slide control, I think. Not able to move to the next slide in between. So I think she's the next one, right, Harshita?
Yes, ma'am. Yes,
Yeah.
ma'am.
So please invite Dr. Shipra Kamal. She's a consultant developmental and behavioral pediatrician, director of Udan Pediatric Neurodevelopment Clinic from Ranchi, Jharkhand. So welcome, Dr. Shipla. Please begin with your presentation.
Thank you, ma'am. And I thank all my mentors and guides for providing us with this opportunity. So, ma'am, the previous slide, please.
Yeah. There's some problem. Is it?
Yes, ma'am. So, my study was on behavioral parental training in managing sleep disturbances in children with autism spectrum disorder. How effective is it? This was done under the guidance of Dr. Leena Srivastava, ma'am, who really does not need any introductions. She was the past chairperson of IP NDP Chapter 2024 and is the head CDGC at Bharati Vidyapeeth, Pune. The next slide, please, ma'am. Yes, ma'am. So, a brief study design. Our aim was to study the effectiveness of behavioral parental training in managing sleep disturbances in children aged 3 to 10 years with autism spectrum disorder. This was an open label randomized control trial, and the study was conducted between April 23 to August 23. A brief methodology: children aged 3 to 10 years diagnosed with ASD. After taking parental consent, sleep disturbances were diagnosed by administering the Children's Sleep Habit Questionnaire, which is the CSHQ, on which a score of 41 or more, they were recruited and randomly allocated to intervention or control group based on random number table. So the control group were routinely intervened for autism spectrum disorder. Apart from that, the parents were asked to maintain a sleep diary for the entire sleep study duration. The intervention group, apart from the routine intervention for autism spectrum disorder, were also given a handbook on behavior training for sleep disturbances. The parents were given a one-on-one 30-minute session, which covered protocolized points by the investigator. Parents were asked to maintain a sleep diary for the sleep duration, and a telephonic follow-up call was given after 2 weeks. CSHQ, that is the Children's Sleep Habit Questionnaire, was re-administered, and sleep diary was analyzed after 4 weeks and 8 weeks for both groups. The next slide, please, ma'am. Coming to the backbone of our study, which was the behavior parental training, coming to what does it actually entail? So while taking the one-on-one session and in the handbook, what we really stressed upon was parent education. Why is sleep necessary? Why is sleep disturbed in children with autism spectrum disorder, and how it leads to a vicious cycle of maladaptive behavior leading to decreased sleep and the need for effective sleep in children. They were also taught about recommended hours of sleep in children as per American Academy of Sleep Medicine. They were taught about sleep hygiene, which is nothing but a set of habits which gives the children certain cues on to sleep onset and maintaining effective sleep. The parents were also asked to maintain a visual schedule for bedtime routine, an example of which is given on the slide, which was included in our handbook. Parents were taught for specific interventions like bedtime feeding for sleep onset delay, sleep restriction for early awakenings, schedule awakening for nighttime awakenings which occur at a specific hour. The next slide, ma'am, please. Coming to the result, one of our objectives was to determine the prevalence of sleep disturbances in children with autism, which came to 69.3. When compared to other Indian studies, these studies have put the disturbances between 60 to 60.2% to as high as 93% in other studies. Then coming to the result of the RCT, for the intervention group, the improvement in CSHQ scores from baseline at 4 weeks and at 8 weeks was statistically significant, whereas no statistically significant improvement in CSHQ scores were seen in the control group. How is this study relevant to our day-to-day practice? Now, I know that population data cannot be extrapolated to individuals, but even then, coming to a 69.3% of sleep disturbance, almost 7 out of 10 kids that we see in our OPD have associated sleep disturbances, which tells us that screening for sleep disturbances is a must. We should ask parents whether their child is sleeping well. And if we are confident enough, we should always administer some tool for sleep disturbance screening. If the sleep in child is disturbed, then we can go for behavioral interventions which aim at reinforcing healthy sleep promoting behaviors and which aim at decreasing the behavioral patterns that are detrimental to sleep. And like our RCT demonstrated, parent-based approaches do work well in decreasing the sleep disturbances in children with autism spectrum disorder. The further reading and references, I have narrowed it down to too much, but For my colleagues, I would really ask them to read up on the last point, which is practice guidelines in 2020, given by the American Academy of Neurology in treating insomnia in children and adolescents with autism spectrum disorder. Thank you so much. If you have any queries, you can reach out to me at shipra.kamal@gmail.com. Ma'am, the last slide. Thank you. Thank you again.
Thank you so much, Dr. Shipra. So next speaker will be Dr. Hilal, Consultant Developmental Pediatrician, New Horizons Child Development Center, Mumbai, formerly associated with PD Hinduja Hospital Medical Research Center, Mumbai, completed institutional and IAP fellowship in developmental pediatrics, has publication in the field, special interest in advancing autism care and outreach on a global scale. Over to you, Dr. Hilal.
Good evening. I would be presenting my research thesis entitled Clinical Profiles of Children with Diagnosis of ASD. So as we know, ASD is a complex neurodevelopmental disorder characterized by social and communication deficits, stereotyped interests, and repetitive behaviors. It is detected in early childhood. However, the age at which it is diagnosed is much later than the actual time of onset. So given the evidence that the timing of interventions can have a large impact on trajectories of children, timely diagnosis has a critical significance. So early and appropriate interventions can facilitate better clinical outcomes. The primary aim of this study was to facilitate early diagnosis of ASD in high-risk children, enabling timely intervention and improved clinical outcomes. So the primary objective being to retrospectively assess the clinical profiles of children diagnosed with ASD to identify early indicators and associated risk factors. And the secondary objective being to support early diagnosis and intervention aiming to improve long-term cognitive, social, and adaptive outcomes in children with ASD. So the methodology involved the clinical profiles of children aged 1 year to 18 years of age who had received a formal diagnosis of ASD in the year 2017 were retrospectively examined in terms of the age of diagnosis, gender, precipitating factors, parental age, antenatal illness, mode of conception, type of delivery, whether the child had an NICU stay or not, neonatal jaundice, family history of ASD, severity on GARS, and correlation with DQ. The diagnosis of ASD was made using the DSM-5 after a detailed clinical assessment, and the DQ was assessed by a clinical psychologist, and descriptive statistical analysis was done. Results demonstrated a total of 271 patients were diagnosed with ASD. The mean age of our study population was 3 years, with a minimum age of 1 year. Males outnumbered females by an approximate ratio of 4.6:1. About 75% patients diagnosed to have ASD had a history of neonatal hyperbilirubinemia requiring phototherapy. Majority of the patients had a birth weight between 2.5 to 3 kgs. Amongst the children born through IVF, 33.3% patients were diagnosed to have ASD as per DSM-5, and 20.8% patients were seen to have clinical features suggestive of ASD. The average maternal age at delivery was 26.4 years, while the average paternal age at delivery was 32 years. Children of hypothyroid women and mothers with PIH showed higher rates of ASD, being 20% and 23% respectively, and nearly 28.7% patients had significant family history of neurological or psychiatric illnesses. 31% patients were seen to have borderline social functioning, followed by 26% having a mild subnormality in social functioning, and 74% patients were seen to have a severity level 2 on GARS-3. So concluding, despite the growing evidence supporting diagnostic stability, reliably diagnosing ASD in very young children remains challenging. This study highlights the importance of recognizing early signs that often emerge within the first 2 years and identifying risk factors linked to ASD, offering insights into underlying mechanisms. So this would eventually help in the timely therapeutic intervention, resulting in favorable clinical outcomes. Thank you.
Thank you so much, Dr. Hilal. So our next speaker will be Dr. Prabhavati, her guide is Dr. Nandini Mukur, ma'am. She's a consultant at Cloud9 Hospital, head of Department of Child Development Center, HIGI, founder director, Future Foundation Academy for Autism Excellence. Welcome, Dr. Prabhavati.
I thank NDP chapter for giving me this opportunity. My thesis topic was a quantitative study on effectiveness of developing social thinking in children in autism spectrum disorder. Next slide. So basically, even though the core deficit is the social skill in children with autism, but there are very few social training programs, structured social skill training program for children with autism. So we have developed a program called Mano Vikasa Social Thinking Program at Center for Child Development and Disabilities. So basically, this is a highly structured 18 weeks curriculum which we have developed from different social thinking concepts all over the world. Like we have taken the concepts from We Thinkers Social Thinking Curriculum by Michelle Gracia, Scott's Bellini's Social Thinking Curriculum, and Kimochi's Socio-Emotional Learning Curriculum. We have taken all these curriculums all over the world and we have Indianized it because those curriculums could not suit our children. So we have Indianized the curriculum and we adapted this curriculum to the to our social and cultural needs. So this curriculum was developed by the expert team of developmental pediatricians, the psychologists, the special educators, and also social workers. And we have designed this program. Next slide, please. So to explain briefly about what is social thinking program, so I have just put all the concepts in one slide. So the curriculum, it's going to be an 18 weeks curriculum. So there are lesson plans, okay, from day 1 to day 18, there will be lesson plans. It used to happen on a weekly basis. So every lesson will be carried over for the next sessions. It's going to be like that. The concepts which are covered in social thinking program is first we would teach the children the social greetings. So basic social greetings like hi, hello, good morning, and further advanced social greetings will be done in the curriculum. And we also teach the concepts of friendship. The children are also taught what is friendship and what are the rules and regulations of friendship, stuff like that. And we have some lesson plans. Lesson plans, these are the books we have taken from Michelle Gracia's social thinking curriculum. We have adapted it. How we should plan in a group, what are the activities which can be done in a group, how the child should participate when we are doing a group activity. So these are taught in the group plan activity. Next, we have the concepts of zones of regulation. Zones of regulations is like child will be taught about his emotions and identifying his emotions. Once the child identifies his emotions, we'll also teach a child how to address his emotions and regulate his body and come back to the normal zone. Supposedly, we teach a child like green means happy, blue means sad, red means angry. Then the child will address the emotion, following which we are going to teach a child how to regulate his emotions so that he can come back to the green zone. So for that, we have materials and resources. We teach the child how to regulate his emotions. Then we come to the concept of expected and unexpected behaviors concept. We also teach the children what is expected and what is unexpected. Then we have a new concept called whole body listening. Whole body listening is, so most of the teaching methodologies involve like, look at me, listen to me, come here, sit down. These are the common ways where we tell the child to come and sit in the classrooms. So as a replacement for that, we have come up with a concept called whole body listening. In the whole body listening, in the classes, we are going to teach a child about how to listen from the whole body. For example, we have to look with our eyes. What does the eye do? We see with our eyes, we listen with our ears, the hand should be quiet, the leg should be quiet, and we have to think with our brain. These sort of concepts are taught. So over a period of time, we get the concept that whenever we are in the class, we should look, we should listen, the body should be quiet, and we have to listen with the whole body. By the end of 18 months, 18 weeks, when we use the word whole body listening, the child used to be alert. Then comes the concept of thinking, thoughts, and feelings. What do you mean by thinking, thoughts, or feelings? When we look at something, when we think about the object, when we do something, we feel about the object. These are the stories. We create stories about thinking, thoughts, and feelings, and we are going to get the idea of how to think and how to connect with our thoughts and feelings. Then we teach the concepts of body in the group, how the body should be in a group. Then, as we all know, inferencing is a big problem, children with autism. We also teach them. Inferencing means situation-based emotions. We teach the children about situation-based emotions by books, by drama, by props, and also by the toys. Then comes knowing through senses, how to use the senses. And then once we teach them the knowing through senses, then we teach them theory of mind activities. This is how the program has been designed. So it's a very big program. I have just concised and I have put it into single slide because I was given the time limit of 5 minutes. I have put everything in one slide. Next slide, please. So we assessment, we screened, we used a profile called Autism Social Skill Profile 2 by Scott Bellini. It is a 44 item questionnaire. So before the Mano Vikasa social thinking program, the questionnaire was filled by the parents. After the program, we gave the questionnaire to the parents and we did a comparison, pre and post test comparison using the same scale. And there was a statistically significant difference found between the pre and the post social thinking program in mean standard score of autism in children with autism spectrum disorder. Thank you.
Thank you so much, Dr. Prabhavati. And next speaker will be Dr. Ashrita, Consultant Developmental Behavioral Pediatrician from Mother and Child Institute, Andhra Hospital, Vijayawada and Visakhapatnam. Over to you, ma'am.
Hello, everyone. Thank you so much, seniors, for giving us this opportunity. It's a really informative session. So my thesis topic was effect of multidisciplinary approach on social skills of children with ASD, and my mentor was Dr. Samir, sir. So he doesn't need any introduction. So what we basically did was, because we were doing this thesis I was doing my fellowship during 2020 to 21 time period, and there was a lockdown happening. So we did a retrospective study. Can you please change the slides? So our aim was to evaluate the improvement of social skills in children with ASD after multidisciplinary intervention. So even we also have seen the changes in VSMS scores, and also we have evaluated the factors which is affecting this VSMS scores in children undergoing intervention. So pre-intervention, we have done one VSMS scoring, and then this multidisciplinary team was led by developmental pediatrician, and then we have psychologists, OT, speech therapist, and everyone included in the team. And we have used this human engagement program, which was put forth by Dr. Sami sir during that time period. And the main essence of this intervention is including parents in the intervention. So we have conducted parent engagement programs with the psychologist, and we have explained the skills, because they are the primary persons who are engaged. Based on the severity and the understanding of parents, we have done a weekly session or twice a week session with the parents. And the sample size we got was 47, and this was during time period January to December 2018. And the study tools we have used are VSMS and GARS. So this is from all the developmental centers, New Horizon Child Developmental Center in Mumbai. So the next slide, please. So after the intervention, we have observed that there is a significant improvement when the child was taking 6 months of multidisciplinary intervention. And also first few, there are some of the children have underwent like 1 to 6 evaluations, but preliminary evaluations, first 2 evaluations, they have shown a significant improvement in the VSMS scores. And also we have seen the scores improvement in children with who are having siblings, educational mother, where the mother was educated, and when the parents are involved more than once a week in the parent engagement program. And also we have seen a significant change in the age group between 6 to 12 years also. So parent-mediated intervention is the best possible mode of intervention to initiate evidence-based early intervention, and also to address the prevailing changes in the resource-limited settings. We have seen a significant change using this intervention and human engagement program. Thank you so much.
Thank you, Dr. Ashrita. Our last speaker will be Dr. Hanisha about challenging behaviors among young children with autism spectrum disorders. Dr. Hanisha is a developmental and behavioral pediatrician in Dubai, dedicated to supporting neurodiverse children through a family-centered, inclusive approach. She elaborates with caregivers, schools, and professionals to create an environment where every child can thrive. Beyond her clinical work, she is an educator, researcher, and passionate advocate for neurodiversity, guided by the motto "Enable, Empower, Include Every Child." Over to you, Dr. Hanisha.
Thank you, Ms. Harshi, for the introduction. Very good evening, everybody. Thank you, IP NDP chapter and all the organizers for such a fantastic event. It's really a pleasure being able to participate here today. This is the thesis which was conducted at CCTT Bangalore under the guidance and mentorship of Dr. Nandini Munku. The topic predominantly was to understand one of the very common entities in children with children on the autism spectrum disorder or on the autism spectrum, which was challenging behaviors. So the idea was to try and understand a little more information about this to see if there are any predictable risk factors which can help us in appropriately managing these challenging behaviors in children and having a better overall quality of life for them. Next slide, please. The aim of the study was predominantly, firstly, to understand what was the prevalence of these challenging behaviors in children with autism. What were the different types, frequencies, or severities, and were there any associative factors which were clinically and also statistically significant? Next slide, please. This was a cross-sectional study aiming population between 15 months and 7 years, which was conducted in the center itself, and our sample size was 90, which we performed over a period of 9 months. Moving on, we have children who were categorized from here who had a clinical diagnosis of ASD. Further, this was confirmed using standardized scales to understand the diagnostic criteria and where they were in terms of the severities. All these children's families were provided with a behavior problem inventory, and an in-person interview was conducted to understand these challenging behaviors. This is just a description to try and see what were the different factors. We had about 50 behaviors which we went through, categorized as either self-injurious, aggressive or destructive, and stereotype behaviors. We tried to understand how frequent they were and what was the severity. Moving on, once we gathered this information of what the challenging behaviors were, we also looked into demographics of the child, which included what was the age of the child, the current age, the age at diagnosis of ASD, what kind of intervention were they receiving, and also whether it was a boy or a girl. And subsequently, we also tried to understand from the clinical perspective how severe they were on the autism spectrum in terms of spectrum-related symptoms, what was their cognitive developmental quotient, adaptive functioning, and their sensory profiles. And then we analyzed the data to try and understand if there was a correlation between any of these demographic or autism-related factors to the challenging behaviors. And amongst the 90 participants, we saw the average age at the time of diagnosis and presentation was roughly about 3 years, with 4:1 boy-girl ratio. 96% of our population was first-time diagnosed when they walked into the center, with nearly half of them being with moderate to severe ASD-related symptoms, and their cognitive developmental quotient being quite on the extreme low range of about 57 points. We further categorized challenging behaviors, like we said, as self-injurious, stereotyped, and restrictive repetitive behaviors, and also aggressive behaviors. We saw that about 2/3 of them had self-injurious and aggressive behaviors. And amongst these, roughly about 10 to 20% of them had these behaviors on the severe range. Stereotypical behavior was very common, almost 90%, and up to 20% of them had it on the moderate to severe range. Overall, there was 94% of children with some form of challenging behavior. Half of them had all three of them, and at least one of them was moderate in about 40% of the population. what was it associated with? Now, for those children who had self-injurious behavior, we saw that their sensory processing dysfunction was quite severe. The more the severity of ASD, the higher association with self-injurious behavior, and those who had poorer adaptive functioning showed more self-injurious behaviors. While there were no significant associations among stereotypical, with aggressive behavior, we saw those of individuals who were diagnosed at a much later age and had more severe ASDs tend to have these behaviors. So all in all, we had a conclusion of the study that challenging behaviors are very prevalent. Like we saw, more than 90% of them had some kind of a challenging behavior, and almost half of them had all three of them, all three types of challenging behaviors which they had shown. And we also understood that there were certain demographic as well as certain ASD-related characteristics which can possibly predict that this child is potential for having more significant challenging behaviors, and the need for early intervention to help manage them much better and overall improve the outcomes of the child. Next slide, please. So we have no conflict of interest or funding. So on our final disclosures, thank you.
Thank you, Dr. Hanisha.
So I think we are at the end of the session. Is Dr. Harshi, we are done?
Yes, ma'am, we are done, ma'am.
Okay. So thank you so much for conducting this session also so well. And I'll stop. Yes. Yeah. So with this, I would request Dr. Deepa Bhaskaran, ma'am, the Vice Chairperson of the chapter, to say a few words.
Good evening, Dr. Kavaljeet, Dr. Safar, Dr. Samir, Dr. Indu, all the developmental pediatricians from all over the country and also from the Southeast Asian countries. A very wonderfully curated symposium on autism. The chapter has actually managed to touch all the areas, right from surveillance, screening, in the preschool age. Then you have touched upon transition, adolescent autism, adults with autism, vocational training, advocacy, legal aspects. Very well curated program, I should say. And so proud to see our fellows doing such a wonderful job, speaking very confidently, very precise, very clear presentations, and really proud to be a part of their journey. Quite a few familiar faces from there, not only people from CDC, but also from MKC Sir's place, then students who had come to CDC for the exam. Extremely proud of all of you, and very nice to know that we have got so many youngsters who are doing such good work in the field. And kudos to the NCDP chapter also for organizing such a wonderful seminar. Thank you.
Thank you, ma'am. Dr. Zafar Minai, I would request you to please say a few words.
Dr. Shambhavi is there. First and foremost, I think she deserves all the applause for all the hard work she takes in managing the fellowship programs, formulating this wonderful program. Dr. Shambhavi, please.
No, thank you so much. And I think it was so heartening to hear from all the fellows. You all have presented so well, and we are so proud of you. And this was, sincerely, I'm saying this was a program which was conducted by the fellows. My only contribution was initiating it, and to Dr. Indu Surana also for managing and coordinating the meeting. So
thank you. Thank you, Dr. Shambhavi.
So over to Dr. Zafar, please.
I think Dr. Hemsagar sir, you are there representing Sanbepa. Dr. Ehsan was there. Your comments are from Nepal. Our senior Dr. Leena Deshpande is also there. Dr. Leena, your views about this initiative, a new beginning, a great beginning.
Hi, Dr. Zafar. Yeah, this was I got the end of it because I was busy with the clinic, but it really sounded very confident presentation, and I think I saw the whole the topics and everything was very well covered. So I think we have done a great job managing to give the relevant topics, the clinical as well as the ones which are essential for the pediatricians to know about the legal aspects as well. So great job, Dr. Shambhavi. Amazing coordination you are doing for the fellowship. And Dr. Indu is doing a great job, doing the admin work. It's not easy, along with the rest of the things. And Dr. Zafar, you're always there. Dr. Kaval is there to guide them. So yeah, great job. Thank you.
Dr. Hemsa, Professor Hemsagar, sir, your comments from Nepal, they would be really empowering us.
Oh, Dr. Jafar, it was such a great program. I enjoyed thoroughly. I was there throughout the session from the beginning to the
Yes, sir.
end
Thank you. Thank you so much.
right now. And believe me, I think this program has given complete insight on autism from the beginning until adolescent and adult and covered all the aspects. It has benefited a lot, I guess, whoever have joined and listened to the program session today. It was immensely educative and great work chapter is doing. We are really proud of everything our chapter is doing, and we all are getting involved. Thank you so much for organizing such a beautiful program. Congratulations. My hats off to all the speakers. Thank you.
Thank you, sir. Thank you.
So it was really a mega, it was a really a mega autism symposium, you can say. So many participants, and till this fag end of the symposium, we are having more than 50% of the participants on YouTube also we are having. And it was more of a family reunion, I can say. Just see the happiness in the words of the mentors, those who have joined when they are seeing their fellows presenting those cases. So it was a fantabulous job, and obviously the whole team worked so well for it. So we are very happy. And another thing which I would like to say, that there are some things which we are doing for the first time. So this was a YouTube screening which we tried for the first time for our chapter also. So again, that is again a big development on our part. So
you didn't appear as first time, first time doing these things. It looked so experienced one. It was
Thank you
great.
so for being here. You made it an international symposium by being here.
There were many parts where there were many colleagues from South Asia. I really thank all of them for joining. I now take formally the responsibility of thanking all my learned fellows who did a fantastic scientific work. It is a great beginning. Believe me, this is a beginning. It's not the end. The only thing is, I think from now on, we cannot be advocates for screen time reduction, because the quality of presentation was so wonderful that we are glued for last 3.5 hours with the screens. So with my obsession for early intervention, I feel not only will have more functions like this, but for more social this thing, I think I propose on behalf of chapter to have a live in-person, I would say, young developmental pediatrician conclave or a congress, which will give us an opportunity to meet in person, have better social this thing, so that we are not labeled autistics because of our obsession of learning and such a great learning from all of you. Number one. Number two, I invite all of you to register for our national conference for Srinagar. Please, you all are invited there. I will try to not only involve you in activities, but your presence brings a fresh air, a fresh hope, great light that the future holds in this cause. I request as the editor-in-chief, I would have loved to see whether the presentations which were there in the last session, if they could have highlighted where they presented and which journal they got it published. But I request every fellow who is doing so wonderful, great work, please get your thing endorsed by getting it published in our Indian Journal of Developmental Pediatrics. We are indexed now and we are all going for DOAJ. Your support, it's your journal, it's your journey, but it only becomes more wonderful when everyone participates. This concept, as I said, initiated or I would say envisioned by Dr. Sameer, then definitely we have this program now for next 2 years. As you know, the Hyderabad Declaration. So this journey would be a long drawn journey. We'll have more such functions and more events like this, in addition to live activities or in-person activities. So it would be a great, I hope, activity to monitor. But the light of this sharing of knowledge, putting academics before politics or individuals, which Dr. Samir has envisioned. I think we need to empower him as well, because then this light will spread not only from neurodevelopmental pediatrics chapter, which has this great beginning, but to more to general IIP if he is strengthened. So with these positive words, hoping to meet you all in Srinagar, and maybe with a practical and a live in event in this year also, and definitely for next year. We look forward to your continuous support, your guidance. It was really wonderful listening to all of you. Thank you, everybody. Dr. Indu. Unmute yourself. You are muted.
Okay, so we leave for today. Okay, thank you all.
Thank you. Thank you.